Oh,
Good evening, everybody.
Good evening, Chandrama.
Good evening, everybody. Sorry, there is some
Chandrama.
glitch. I'm not able to show my PowerPoint, which I had prepared for the CV of all the speakers and the panelists.
ma'am, we are
My
live.
laptop has crashed and I'm using a Mac, which I'm not used to.
No issue. You
So
can
I'll
just
just
read it.
speak out orally.
So,
And
Amit, we are live.
We
You
are
can
live.
talk.
We are live, please.
so, good evening, everybody. Welcome to this global webinar on Top Gun in glaucoma. In this webinar, glaucoma webinar, we have the top guns of glaucoma, the top achievers who have defined glaucoma and who have refined the surgical treatment and the diagnostic management part of glaucoma. We have our esteemed panelists, but before I introduce the panelists and our speakers, I welcome all of you all and I would request my chairman scientific committee, Dr. Namrata Sharma, to please come and say a few words about this webinar.
Thank you, Amit. I think we are going to have a wonderful scientific session in glaucoma. And all thanks to you for organizing this and coordinating this. We have luminaries from all over the globe, and thank you so much for being a part of this, especially Dr. Paul Palmer, Dr. Keith Barton, Dr. Benjamin Zhu, Dr. Noel John, Dr. Fabo, and Dr. Leong. And I'm sure all the aspects which are related to glaucoma and which everybody actually would want to know what to do in these situations, whether it's medical treatment or surgical treatment or management of complications would be clarified at the end of the scientific session. So thank you, Amit, and I think we can start the scientific deliberations.
Thank you, Dr. Namrata. And for this whole webinar, let me introduce myself. I'm Dr. Amit Porwal, the moderator for this session. A brief introduction about myself. I'm head of the glaucoma services at Choitram Netralaya, Indore. I'm a teacher and trainer in glaucoma since 21 years and have been awarded with the honorary FICO degree in glaucoma by the FICO Collegium. I'm also on the editorial board of Journal of Ophthalmic Research and Practice, and I've delivered more than 750 talks and I have 30 publications and I've written 8 chapters in books. So I'm going to moderate the whole session and to introduce our chairman scientific committee, Dr. Namrata Sharma. She doesn't need any introduction. She is globally a well-known ophthalmic surgeon. She is working in the Department of Cornea, Cataract and Refractive Surgery in AIMS, New Delhi. She's done a fellowship from Moorfields Eye Hospital and she's the chairperson of the scientific committee AIS office. She's the first Indian to be inducted as a director at large international member in the Cornea International of USA. She is featured in the 2023 Stanford list of top 10 highly cited ophthalmology researchers in India and top 2 scientists in the world conducted by Stanford University. She is among the list of the 100 powerful women ophthalmologists in the world. Welcome, Dr. Namrata ma'am. And coming to the panelist, we have Dr. Vijaya Lingam. She is a distinguished senior consultant at Shankar Netralaya, Chennai. She has published 178 papers, authored 10 chapters, and delivered 180 lectures. She was the principal investigator for the Chennai glaucoma study, a follow-up of subjects with glaucoma, ocular hypertension, narrow angles, and Chennai eye disease incidence study. Apparently, she's having some health issues, so she might join or she might not join. Then we have my own mentor, Dr. Krishnadas sir from Arvind Eye Care Hospital. He's a consultant ophthalmologist and trained glaucoma specialist over there. He's involved in patient care, teaching, training, and clinical research since last 34 years. He's done his visiting fellowship in UIC, Wills, Wilmer, and Bascom Palmer Institute, part of the collaborative research initiatives in the Arvind Eye Care system. He's got 96 peer-reviewed publications. He's got oral presentations at national and international conferences, and he was recently awarded with Dr. Bhaskaran Award and Dr. V. Velayudham Oration Award. Welcome, Dr. Krishnadas sir. Then we have one more star panelist, that is Dr. Tanuj Dada sir. He is well known in the Asia Pacific, not only in the Asia Pacific, but globally also. He is the professor of ophthalmology and head of glaucoma services at RP Center, AIMS, New Delhi. He is on the board of governors of the World Glaucoma Association, board of directors of the Asia Pacific Glaucoma Society, associate editor of the Journal of Glaucoma, editorial board, American Journal of Ophthalmology, and he has over 350 index publication. Welcome, Dr. Tanuj. Then we have Dr. Rita Damankar. She is the head of the glaucoma department at Lakshmi Eye Institute, Panvel. She was trained by Dr. G. Chandrasekhar at L.V. Prasad and Dr. Ravi Thomas at CMC Vellore. She did her fellowship training in glaucoma under Dr. Paul Palmer at Bascom Palmer Eye Institute, Miami in 2004. She has given invited talks on glaucoma at various national and international forums. And she is one of the first ophthalmologists in India to start using selective laser trabeculoplasty. Welcome, Dr. Rita Damankar. And my own teacher, Dr. Professor P. Satyan, Director of the Satyan Eye Care Hospital and Coimbatore Glaucoma Foundation, ex-Honorary General Secretary of the Glaucoma Society of India. He's a visiting consultant and professor for the IBN Rashid Hospital, Bahrain. He was the former chief of glaucoma services at Arvind Eye Hospital, Coimbatore. And he's got his glaucoma training at Arvind Eye Hospital, Madurai, Bascom Palmer Eye Institute, Miami, John Hopkins, Wilmer Eye Institute, and New York Eye and Ear Infirmary. Welcome, Dr. Satyan. Then we have Dr. Chandrima Paul. She's the director of BBI Foundation at Kolkata. She's the president of the Kolkata Association of Ophthalmology. She's the founder secretary of the Glaucoma Society of Kolkata, immediate past general secretary of the Glaucoma Society of India. She is trained at Glaucoma Services, Moorfields Eye Hospital, London, and she is recipient of the DB Chandra Award by AIOSSC, BK Mitra Award, which is the highest award by the state of OSWB. We have Dr. Rajul Parikh, our next panelist. He's the director for the Sriji Eye Institute and Palak Glaucoma Care Center. He's the society editor of International Glaucoma Review since 2018, member of the Educational Committee, World Glaucoma Association, chief editor of the Glaucoma Society of India Guideline First Edition. He's got 80 publications in peer-reviewed journal and 17 chapters, including book in World Glaucoma Association Consensus book. He's recipient of the FDC Award and the Bell Pharma Award from the Maharashtra Ophthalmological Society. And our last panelist, Dr. Ankur Sinha. He's the director of Max Vision Eye Care Center. He's done his MD and fellowship in squint, glaucoma, and neuroophthalmology from the prestigious institute AIMS, New Delhi. He's got 22 index and 40 non-index publications, more than 25 pre-papers, posters, and video presentations, more than 250 talks. He was the organizing secretary for the annual GSI conference in Jaipur, and right now he's the secretary for the Jaipur Ophthalmological Society. So welcome, Dr. Ankur. So with this welcome of all our esteemed panelists, now I start the webinar with our first speaker. He needs no introduction. He's none other than Dr. Paul Palmberg. Dr. Paul Palmberg is the professor of ophthalmology emeritus, Bascom Palmer Eye Institute, University of Miami School of Medicine. Now, he sent me, I asked him for a one-slide CV. He sent me a CV which has his contribution. And this contribution, what he has given, has changed the whole concept of glaucoma diagnosis, management. So what are his contributions? Just to brief it, he is the basis for target pressure in AGs and CIGTA study, safety valve trabeculectomy, bleb and scleral flap compression suture, transcorneal needling technique, slit lamp procedures in glaucoma, role in introduction of the RD, AO Lifetime Achievement Award, Schaeffer Lecture, AGS Surgeon in 2014, Educator in 2018, Annual Meeting Honorary in 2013, and EPGC International Award in 2014. Dr. Paul, your contribution for the innovation of RD implant, which has revolutionized the tube surgery in India, is wonderful, and we all are very thankful to you and the team Arvind Eye Care System to get us this RD implant. So over to you, Dr. Paul, sir. We are not able to hear you.
Please unmute, Dr. Paul. Please unmute.
My goodness, excuse me. Okay. And screen share. Yeah. And share that. Can you see my screen?
No, we are not able to see yet.
Okay, share. There.
Yeah,
how about
now
that?
we can see.
Okay, great. So I'm very privileged to be able to participate in this meeting. I've been to India several times to wonderful meetings, and worked at Arabin for 3 weeks with the device. And it was really Alan Robin who connected me there with George Barbelt's device. So I was just a cog in the wheel for it, but I'm so pleased at how it has turned out to be useful. But let me talk to you now about trabeculectomy. And over the years, I've evolved to a new technique of doing trabeculectomy that I believe, and I'll show you data, gives longer term results. And that's really important. You don't want something that works 3 years, 5 years. You want something that's going to work 15, 20 years, the lifetime of the patient. And also, at the same time, we want to reduce leaks and infections and hypotony. And so I'm going to talk about specific design features to try to accomplish greater efficacy, lesser complications. These are my disclosures. None of them are really relevant to this talk. So what do we want to do? We want to get the pressure low, but not too low. What's optimal? Well, many patients will do fine with pressures that are reduced 20 or 30%, maybe to the middle or upper teens. But there are some people who really are not going to stabilize as best you can for glaucoma until you get to the low teens. From a theoretical standpoint, the optimal pressure for somebody with glaucoma. Not everybody needs it, but even for the most sensitive nerve, the optimal pressure would be about 8 to 12 with a bleb off medication. Now, that's usually sufficient, actually, from clinical trials to stop glaucoma from getting the visual field from getting any worse than just aging. Can't do anything about aging. But if there is progression and people are on medications that divert aqueous or reduce the production of aqueous, they may have a pressure that's low in the clinic, but goes much higher, particularly if they drink a large quantity of water a lot. Some people think it's great for health. One guy had a pressure of 12 and he said, and he was getting worse. And I said, you drink much water? He said, yes, 6 liters a day. It's really important. And I had him drink a liter and his pressure went to 28 and stayed there for an hour or two. And he did it 6 times a day. So I told him, we need to deal with that. But if you've had a trab and the pressure is down around 8 to 12, theoretically, that should be the best. It's the best you can do for blood flow to the optic nerve. It's the best you can do for pressure gradient across the optic nerve. And fortunately, it actually works very well in normal tension glaucoma, high pressure glaucoma. So there are 3 layers of blood vessels in the conjunctiva and tenons and the scleral surface. And if you look at the eye, you see the ones on the surface in the conjunctiva. If you move it back and forth with your finger, you see the tenons ones will also move, but the vessels coming out the superior rectus, those are on the scleral surface. They will not move if you move the conjunctiva and tenons side to side. Now, the best way to make a conjunctival flap that's not going to bleed and it's not going to leak is to make a big conjunctiva tenons flap. We don't make conjunctival flaps. We make conjunctiva tenons flaps. And to do this, I have found it's much better to get under the intact tenon sheath. So if you start, here's a second-year resident, I'm guiding them. Start with a relaxing incision, get your forceps under and evert the tissue so you can see the insertion of tenons, which is about 1 to 2 millimeters posterior to the insertion of conjunctiva. And keep getting underneath that. Pull the scissors down to the limbus as you cut. Evert, get under the tenons. Don't cut the tenons except right at its insertion. And then you will have an intact sheet of tenons capsule. And here we're going on along. I'm telling them evert, evert. 1 time spreading is enough. And get all the way around. And then make a relaxed incision on the other side. Now people think, oh, big conjunctival flap. I don't want to make a big flap. It might leak. This is actually the much better one not to leak. And then I spread back to each side through the intermuscular septum. And the reason I do that is I'm going to put mitomycin sponges there. I want the drainage to go through lymphatics posteriorly into the orbit. I do not want to have a lot of microcysts, which are cracks in the conjunctiva. So think of the conjunctiva as a relatively watertight cellophane and tenons capsule as a sponge that fills with fluid. And to avoid bleeding, you want to cut off the tenons right at its insertion and allow aqueous to spread through tenons when you've finished your operation, rather than up through cracks in the conjunctiva, which we call microcysts. Don't want to see a lot of microcysts, actually. So here is the alternative. Wonderful surgeon, Chris Tang, and this is on the web. And you notice they're making a little conjunctival flap, and the scissors are spreading back and cutting, and they're doing it blindly. Now, if you're cutting back like that, look at the blood. If you cut off tenons and conjunctiva at the limbus, the only place that bleeds is right at the limbus. You do this, and you're bleeding all over inside tenons because you're cutting the tenons. So the blebs that you end up with that small conjunctival flap are like this. They have microcysts. They have transparent areas in an ischemic bleb when you've used mitomycin. And these transparent areas are radial cuts in tenons capsule, so that instead of being a sheet that's hydrated, it hydrates more in these focal areas where you have radial cuts. And these blebs are not always watertight. They're going to have microcysts, they're going to have leaks, they're going to have infections sometimes. If, on the other hand, you've cut off and put tenons back the way I'm going to show you, and I have shown you, you get an ischemic bleb. you don't get very many microcysts. You get a pressure around 8 to 12 if you adjust the scleral flap and use a big dose of mitomycin. This is a safer bleb. You can use a higher, longer dose of mitomycin. As a result, you can get greater efficacy. You can have the operation work 7, 10 years or more. Now, Peng Kaw is a hero of mine. He came up with the idea of using fornix-based conjunctival flaps and using a big dose of mitomycin, and found that really reduced a lot of the blood problems over what we were doing before. I've made a modification, and that is to put the mitomycin through the intermuscular septum to each side so that I can have drainage way back into the retroorbital area. That's in addition to what Peng had come up with. And then to not get hypotony with a higher dose of mitomycin, I make a valve-like incision. I started using this in 1988 when I began doing anti-metabolite filters with 5FU in 1982, but in primary cases starting in 1988. Excuse me, it's a canal and a tunnel. It's about 3.5 millimeters wide, goes out 1 millimeter into cornea, so it's 2 millimeters this way. And I want equilibrium flow, the pressure to be about 4 to 6. You can estimate that by pushing on the cornea and cutting a little more until you get that. Now, that is enough resistance that the chamber will form before there's any flow, so you don't need an iridectomy. Then I put stitches in and carefully adjust the pressure to about 8 to 12. We used a tonopen early on to know what that was. And then you can tell you're pushing down on the cornea. You saw how I did that with a cannula. You can learn to estimate the pressure. Now, so the pressure at the first stage of the wound is 4 to 6 at equilibrium flow, and then with the sutures, 8 to 12. And because we use a big dose of mitomycin, this stays at that pressure. The technique was published in Ophthalmology. The results were published in Archives of Ophthalmology, and our results on combined were published with Dr. Ishida from Japan. No iridectomies needed, and we had no net visual field loss in 10 years of follow-up. Now, first of all, what is the pressure? The flow through this device, this short valve-like incision, it has a steady flow, and therefore the opening and closing pressures, as you wish, would be the same. And we did, in fact, have a pressure of 10 the first postoperative day. It can be done. If you have a big scleral flap, the opening and closing pressures are different. There's going to like blorp flow, stop, blorp flow, stop. This is predictable and adjustable. And then because you use a big dose of mitomycin, it's pretty steady. And out through 10 years, we had an average pressure of 11. Now, about 30% of the people by 10 years failed, and we needed to reoperate them, or they had a cataract and we reoperated them. But this is what can be achieved. And at an average pressure of 11, then when we close the conjunctiva this way with a big flap, you must have a secure closure. And you start off with a 10-0 nylon going straight down into sclera, coming across up through the conjunctiva, tenons, and back down through. You need a square wave bite. A square wave bite will compress, but it will not claw through the tissues. And you don't want a skimming bite where you enter with your needle parallel to the surface and have a shallow entry, get deeper, and then a shallow exit, because at the end of your surgery, your conjunctival flap is watertight, but 2 or 3 days later, it will tear through that shallow entry and exit of the sclera, and you can get a leak 3 days later. And you say, oh, how am I getting this leak? Well, it's because you use this kind of a bite instead of that one. And then here's the closure at 10-0, a nylon there. And then we want to close to the sides. And to do that, we take an 8-0 Vicryl, drive the needle into the sclera, come up out of the sclera with the tip of the needle just emerging, pull the conjunctiva and tenons on that side over and impale it at this location in over the needle. Then pull the needle up through, take a bite of the corner of this relaxing incision, and go over and tie. And then that is a temporary tie. That suture can be pulled to the side by your assistant, which will then pull this part of the wound out where you can see it better. Run the suture out to the apex, take a bite of the apex, slide the needle back underneath. And then when you're tying, you can now make a square knot. And as you're pulling, you pull more on the hand that's above, and therefore the knot slides underneath. It's buried. The patient doesn't feel it. You cut it off short, and the patient doesn't have it. And this way of closing does not bunch the tissues here. It just compresses them. And you do the same thing to the other side. And this is quite watertight. Now, afterwards, I'm going to inject the antibiotic steroid with a cannula into the Tenon's capsule. I just put the cannula underneath this tight flap and inject it and hydrate the Tenons. Very quickly has shown that hydrated Tenons, fluid flows through it a lot better than if it's compressed. And if one makes a small conjunctiva Tenon's flap and has compression across this area, it's tight, pulling here and here, you're actually compressing the Tenons. You are cutting down the flow. You're also putting additional pressure on your scleral flap, and you find it very difficult to set a pressure at the time. I want flow right away. I want it going posteriorly. I'd like the pressure to be 8 to 12 at the end of the procedure. Now, if the pressure was 40 or 50 pre-op, you might use one additional suture in the scleral flap to make it 18 or 20 for about a week and then laser it or release it so that you're bringing the pressure down in maybe to reduce the risk of a suprachoroidal hemorrhage. Now, what are the results of this? Our success of being under 21 millimeters of mercury and 20% reduction or more was 85% at 5 years. It was 68% at 10 years. If you're interested in being 15 or less, we had a success of 73% at 5 years, 60% at 10 years. So that the big dose of mitomycin applied for a long time is much more effective than shorter doses. You can get great results at 2 years, but the patient's going to live longer than that. Now, let's compare it to what happened in wonderful surgeons who were in the primary tube versus trab trial that Steve Getty put together. And they're using 0.4 mitomycin, big dose, but only for 2 minutes. The failure rate of getting under 21 and 20% reduction at 5 years was the failure rate at 5 years was 35%. I've just shown you if you apply the same dose of mitomycin or a little more for 5 minutes, we had 15% failure by the same criterion and only 32% failure at 10 years compared to 35% failure at 5 years. So bigger dose of mitomycin applied longer is more effective, but you better do the conjunctiva tenons management and the valve-like incision or something like the Zen or the microshunt if you want to safely get it down without hypotony. So what are the results? We went from an average pressure of 26 on medication to a pressure of about 11 during follow-up. This was a prospective study in the sense that I asked everybody to come back every year, but they were not signed up for a study and they didn't all come back, and a third of them were coming from another continent. So we do have some follow-up, but everybody stays in this study whether they're reoperated or not. This is a relationship between pressure and what happens to your visual field. And what happens to your visual field when the pressure is around 11 is it didn't get worse. There was no net loss for this whole group of patients through 10 years. Now, some people did look worse, especially if their pressure had gotten higher, but some people were better. Some glaucoma loss is reversible if you get the pressure down. Some cells are in the process of dying, they're not functioning, and they can come back to function if you get down. And in fact, as Kyoko Ishida pointed out to me, because I missed this, she's the one who taught me on this. If you are getting down to 13 or less at all visits, down from 26, you actually improve about 2 decibels. And these people weren't operated on because their fields were getting worse and getting some regression of mean on the fields. They were being sent to me because their pressure was way out of line by doctors in Miami who don't operate. And it was because the pressure was so high, not because of field loss. And then if your pressure ends up being in the intermediate zone, 14 to 21 during follow-up, well, you got better by about 1 decibel. And those who had a pressure in the mid to upper teens, and remember, these are pretty advanced patients, minus 14 decibel fields before surgery, they could be stabilized somewhat, maybe a little worse, and then start getting quite a bit worse when they would fail. Now, in comparison to this pressure of 11 with careful adjustment and longer application of mitomycin, In the primary tuberous trap trial at 5 years, the pressure was 13, and they were back on 1.3 meds. So I'm comparing it to excellent surgeons. I'm not a better surgeon. I think, have a better strategy of a longer application, and I'd like to convince you you can do that safely if you manage the tenons the way I talked about, so you don't get bleb infections or leaks, and if you use a valve-like incision and you've learned how to do it carefully. Now, what's the proof that getting the pressure down there helps besides my data? The AIOSSC study, which showed that if your pressure was always quite low, you average 12, and you're under 18 at every visit, and that doesn't mean aim for 16 or 17. You're not going to be under 18 for 8 years if you do that. There was no net visual field loss in that trial. Now, I got the World Glaucoma Prize. I didn't do any of the work. I didn't even write the paper. I just said, let's see what's the best you can do. What if the pressure is always under 15 all the time, as Paul Chandler suggested should be done, and as part of my target pressure concept? And by golly, it was a flat line. Now, this is Doug Gasterland's work. He deserves the credit for having shown this. I just asked the right question. And then, here are my patients, the whole group of patients, not just 1/4 of them, at a pressure averaging 11, no net field loss. So you can stop glaucoma from getting worse if you get the pressure low enough. Now, in combined procedures, where we didn't have to go back and do a cataract afterwards, the field, we were also able to make the pressure about 11 in large follow-up. This is 265 patients, but more than 200 that had a good, could do a visual field. And we were able to follow more than 100 of them out 6-7 years here. So here, after taking out the cataract, of course, the visual field improved by taking out the cataract. After that, it was stable. It was stable. With a big dose of mitomycin, a combined procedure is every bit as effective as a primary one. Now, what about mild early cases? We had the SIGIT study, where you went on medical therapy first, or you went on filter first. If your pressures were always under 13, and we published this, and it was really Kyoko Ishida's idea, of course, but I thought, well, we ought to apply it to early cases as well as advanced cases. If you were under 13 all the time, and here you had 10 visits in the first 5 years, 18.7% of the time, your field looked better by 3 decibels, 3 decibels better, and 6% worse, and noise in that test was about 6%, the reproducibility. So the difference is real. And about one patient in 8, not everybody with glaucoma, 1 in 8, if you get the pressure to 13 or less, your field will improve by about 3 decibels. If you're in that intermediate category, you do a little less well. If you're a little higher than that in the therapy, you're breaking even in the mid to upper teens. These are peak pressures, so the average is lower than that. And if you're higher than that, well, you clearly, on average, are going to get worse. So if we're going to have to operate on somebody, get it low, use a long enough dose that it will last for a appreciable number of years. And if you start with a happy bleb, you can continue with a happy bleb throughout the life of the patient, and you're taking care of them. And blebs are like babies. Making them is fun. Knowing the anatomy helps. If they wet themselves, don't wait to fix it. Don't lose that bleb, and you pray that they have a long and happy life. And I thank you so much for having me here. And I'd like to say that my narrated PowerPoints are available. If you contact me, I would be delighted to give them to you. Use them in any way you want, and change the language on it if you want. And it's you can get them through Mitodoc, MITODOC, Mitodoc at AOL.com or ppombergmed.miami.edu. Send me an email. I will send you a link. Thank you so much. And it's great to see so many of my friends in India. Thank you.
Thank you, Dr. Paul, for such a wonderful talk on how to optimize our trabeculectomy surgeries. I would like to take a quick comment from Dr. Krishnadas and Dr. Satyan and Dr. Rita Damankar for this talk. Any insights from your side?
This is Krishnadas here. Thank you, Dr. Pomberg, for all the practical wisdoms you gained over maybe 5 decades of glaucoma practice. One question I have, you have been talking about the mitomycin sponges, but how do you think in your experience and the role of subconjunctival mitomycin injections in place of sponges.
Well, I tried using injections. I wasn't quite as satisfied that I got flow as far back, and putting sponges through the intermuscular septum on each side was a help. And I had to open up the conjunctiva very widely to do the kind of flap that I do, so it wasn't that much more work. So I really prefer the sponges. Certainly injection in most people's hands who are not doing applying it through the intermuscular septum, then they are getting fairly comparable results. But I think the results I'm showing you are even a little better than what people are publishing where they inject. But you know, both are good, and it's certainly faster to give an injection.
Thank you. Dr. Rita, I think, had a question on the chat.
Yeah.
Before going to Satyan, yeah.
Yeah, I would, like to ask you, Dr. Pambak. Of course, I've, tried your valve trabeculectomy for a very long period after I came back from you. But now I prefer to inject subtenon's mitomycin instead of using those large sponges, because I think we're getting very good results even with that. It helps you dissect the tenons away quite easily when you're injecting the mitomycin itself. That is the first thing. So you don't get nicks in the tenons because you are already giving the injection below the tenons. So you already separated the tenons from the conjunctiva. That is one. But my question actually to you was, you showed us these results for 5 years, over 5 years, and over 10 years. How often do you think would you operate a patient who's got early or moderate glaucoma? In our setup, we normally don't use surgery as the first line of treatment. We normally still go with medications. And it's only when, medications don't work, or either they're very poor compliance, that's when we think of surgery. So what are your comments on that?
Yeah. So I think now with the LIGHT study out of England, that laser trabeculoplasty, at least in the populations that were studied, and this should be studied in India, got a much better result than medical therapy. And the other advantage of it is you have aqueous flowing through the collector channels, so that if you then want to have use a MIGS, for example, you're getting pressures that are in the low teens, as it was expected, based on, normalize. If you were to tear out the eye bank eyes, if you took out the trabecular meshwork, you'd get rid of almost all the resistance. You would go to an episcleral venous pressure level of about 8, 9, 10. And that didn't happen in the trials where people were on medications that reduce aqueous or divert it through the ciliary body, the prostaglandins. You ended up with pressures that are in the 15, 16, 17 range and back on medication. So I think the SLT first. I would be inclined, seriously, would be inclined to do a MIG second, and to use, this is a hypothesis, and to use medications third, because you're losing the MIG's effectiveness if you do it that way. And certainly the compliance with a MIGS is better. So when I was diagnosed with glaucoma a year and a half ago, I had a cataract and I had the normal tension glaucoma in my left eye. I had a hydrus put in, and my pressure is running 10 to 12 on nothing. And but I think if I had been on medication for many years before, I would have had to go on to filtering surgery if that didn't control my pressure well enough. Also, it's now known, I should mention this as an aside, that Norvasc, also known as amlodipine, has been reported from the UK Biobank and from the US All of Us study to be about a 40% greater risk of glaucoma damage. And I had been put on it 2 years before I was found to have glaucoma. So you should be asking your patients, are you taking Norvasc? And perhaps if they have high blood pressure and they have glaucoma, there might be some consideration of using an alternative therapy, because these are two huge studies giving the same result, that somehow these calcium channel blockers, that dihydropyridone ones, are a risk factor, a significant one for normal tension glaucoma.
Yeah. Thank you, Dr. Pambak. Dr. Satyan, can we take one quick comment from you, because Dr. Keith is waiting he's in the middle of his surgery.
Yeah, sure. The only question from my side is, when you have been doing your triangular scleral flap versus the the straight incision, which you have done or you have shown in this video, which one you feel has given you the best of the results? And when I was there, at least we used to give the steroids for a very long time, like 6 months, or some of them were on kind of 2 years, the prednisolone. So can you just give a quick comments on that,
Yeah,
Dr.
in a combined procedure, I would keep them on 1 drop of prednisolone for life, because there's always some chronic inflammation in a patient who's had a combined procedure. In a primary procedure, I want to use it until the eye is really quiet. And so I don't taper off very quickly. If they should get a cataract, okay, they could get a cataract. But I found that one of the things I think helps preserve the function of a trab is to be on steroids. So I would use it at 3 months at least. Maybe only 1 drop a day towards the end of that. But if there's any inflammation at all, and of course, many of the patients have been on medication for years, so their eyes were chronically irritated. Those may particularly need to have steroid a little longer. And it'll depend on your patient population and how long they've been on drugs.
Is there any change in your triangular scleral flap and the straight incision?
Well, I like the straight incision best because it has a continual, steady flow, which enables me to judge the pressure at equilibrium flow and to know if I need to cut out, punch out a little bit more. I want to stop about a ½ millimeter short, the canal short of the mouth of the wound, because I don't want hypotony. If it sets the pressure at about 4 to 6, it's going to never go under that, even when the nylon stitches melt or are pulled. And one of the things about big dose of mitomycin was hypotony. So the valve was intended to avoid that, and we did have, even with this high dose of mito in primary filters, we had only 4% risk of hypotony, which we were easily able to fix. So the triangular one, the flow is kind of intermittent. It's harder to adjust the flow and know what it is at equilibrium. And that's why I like this one that's kind of like an old scleral tunnel for phaco. And it's so adjustable that I think that's important. And here's Keith Barton.
Thank you, Dr. Pamba.
Thank you so much, Dr.
Thank you for your wonderful insight.
Thank you.
Now we have our next speaker, Dr. Keith Barton. Dr. Keith Barton, he's a glaucoma specialist at Moorfield Eye Hospital. He's a professor of ophthalmology. He's an innovator and has pioneered surgical treatments for advanced and complex glaucomas, as well as minimally invasive techniques. He has been instrumental in the landmark trials that have defined the evidence base for glaucoma drainage device and refined indications for lasers and trabeculectomy, including TVT, ABC, PTVD, TAGS, and the light trials. He co-designed the Paul glaucoma implant and he was awarded the International Scholar Award of the American Glaucoma Society in the present year. And Dr. Keith also founded the ESCRS Glaucoma Day. So over to you, Dr. Keith, and I'm sorry to keep you waiting. Your patient is on the table, I already know. Over to you, Dr. Keith.
Apologies, yeah, I set aside, it's a busy list today and I set aside a little bit of time, but we're running out. You very kindly asked me to speak about tube complications, and it's difficult to cover that in a brief time period to actually, if you're actually talking about fixing them. But basically, you know, I've a number of financial disclosures. I work with most companies to some degree or other. But tube complications kind of break down. I hope you can see the slides okay.
Yeah, we can see the slides.
And I hope you can hear me.
Yeah.
Break down into kind of hypotony, corneal damage, erosion, retraction, obstruction, and diplopia. Probably the biggest complication of all is that the pressure is too high and it's not under control, but we don't really call that a complication. But hypotony was devastating in the early days of tube surgery. Largely because nobody quite understood the importance of the technique, and at the time most people were only doing a couple of tubes, you know, now and again. They weren't really doing them on a regular basis. And the causes of hypotony really are peritubular drainage through the tube, or a ciliary body that can't cope in the first place. And prevention really of peritubular drainage through the tube is surgical technique. And reduced ciliary body function is really case implant selection, which is more difficult. A lot of people like to blame reduced ciliary body function whenever they get low pressures afterwards. But most of the time it's surgical technique. It's not reduced ciliary body function. And it's usually used as an excuse. But there are patients such as that do have reduced ciliary body function. And if you put in a big Barveld and nose, they will get hypotony and they will bite you. Surgical technique for and case implant selection. It's obviously difficult with implant selection to predict exactly what will work for whom, but one size does not fit all. And in general, the Barveld 350, the Paul glaucoma implant, and obviously the ADI in India will give better pressure control than other implants, with certain exceptions that have a high chronic hypotony risk. And these are not just uveitis, but those who've had uveitis from early childhood, or very severe HLA-B27 ankylosing spondylitis type uveitis, people who've got really severe uveitis, especially from early childhood, are the ones that need smaller implants, not just every uveitic. Chemical burns, if you've got that sort of extraoral surface, remember you've probably burnt your ciliary body as well, and it's probably not going to produce much aqueous. And the old style neovasculars that we don't see so much these days, the kind of anti-VEGF type neovasculars, where the ciliary body is very ischemic and the angle is completely closed, and you can see the ciliary processes on gonio, and you can even see the neovascularization of the ciliary processes. These types of, that's if the cornea is clear enough. These sorts of eyes are at a high risk of crashing. And in the ABC study, the only eyes that lost light perception with Barvelds were those with neovascularization. So you've got to avoid the big plates in those sorts of cases, and then hopefully you can avoid hypotony from reduced ciliary body function. Peritubular drainage is relatively uncommon, but this was one case. I saw two patients a couple of years ago in rapid succession, and while I went in to fix the hypotony, this was a girl with Weil-Marchesani syndrome, and she had very severe hypotony, but it turned out that she got quite dramatic peritubular flow. And you can see, I typically would stuff a little pledget of pericardium, fascia lata, or sclera through the hole, but that wasn't going to work in her case. Why did I not reposition the tube? The reason I didn't reposition the tube was I couldn't be sure that the same thing wouldn't happen again. So I chose to keep it the same place. I ended up wrapping large pieces of pericardium around it, almost enveloping the tube. And that worked very effectively in this one case. And then a couple of months later, I saw another one, and this is fairly rare occurrence, but of course, things always come in more than one at a time. And in this case, the tube seemed to be pistoning in and out of the eye when the eye was moving, and that had clearly enlarged the entry site. And again, this was not a case of mine originally, so I don't know what the original implantation technique was like. But again, using this kind of what my Singaporean fellow called at the time the wonton technique, because she thought it looked like a wonton afterwards, and then we patched it over. And so that's peritubular. Those are fairly dramatic examples of peritubular flow, which I say is pretty rare. You've got to make sure the entry site, the time is absolutely watertight, but occasionally from tube movement or for whatever reason, the entry site can widen, although it's uncommon. Drainage through the tube is again modifiable. And if you get typical hypotony and you need to go back and fix it, I would often inject some viscoelastic at the slit lamp while I'm scheduling the surgery, because I don't want the patient getting a choroidal hemorrhage while they're waiting from severe hypotony. And it's my typical tangential small amount. I typically use a small amount of Helon 5 rather than a large amount of thinner viscoelastics. But why? Because Helon 5 sticks around for a few days. And secondly, you can, if you've got a ripcord type suture inside the tube, you can get a very high pressure spike, typically 5 or 6 hours later. And if you use small amounts, 30, 40, 50 microliters, you can protect the patient without the pressure going through the roof, and the Helon 5 sticks around for 3 days. And then if you do need to go back in, the risks are pressure still too low, pressure too high. And that typically the way I try and mitigate against that is by putting a bit of suture up the tube, because typical ligation techniques I've found just too binary. You can never get them exactly right. They're always too high or too low. And often when a patient's got hypotony, you're not trying to get the pressure up by 10 or 20. You're often maybe only trying to get up by 2 or 3 or 4. And that's a 3.0 supramid going into Barvelt. And I typically use 10 millimeters of that, because if you use shorter, I found it slips back down into the anterior chamber. If the supramid is too tight, I use a 3.0 ethylon. And why 3.0 ethylon? Well, 3.0 ethylon is monofilament nylon, the supramid is braided nylon. They're both 3.0. They should be exactly the same, but they're not. The ethylon tends to be slightly thinner. For the finer tube of the pole glaucoma implant, I use a 6.0 proline. You can see this patient's got failed pressure flow as well. This was actually a Nigerian patient, probably the only Nigerian patient I ever had who got the hypotony, because they do tend to scar very, very aggressively. And using the vitrectomy forceps, you feed it up the tube. You can use the micrograspers as well. The vitrectomy forceps have a little bit more maneuverability. That tends to fix the problem. You can, in fact, adjust it. The trouble is if it's too much and you need to, if the pressure goes too high, you can still adjust it. But obviously the patient needs to go back to the operating theatre, which is another pain. And people worry about how do you get at it if the stitch isn't protruding into the anterior chamber. And it's actually very easy. You just tweak the end of the tube and the suture comes out. So you just grasp it, squeeze it, pull, and let go, and the end of the suture comes out. It's actually very easy, but it's something that people tend to agonize over. And then you can take it out, trim it, or whatever. I'm just going to move on because of time. So it's avoid creating hypotony by using large plates and those with poor ciliary body function. Transcameral occlusion with a suture doesn't work in everybody, but it's a simple way of getting the pressure up a little bit without driving it through the roof. And I found it more predictable and easier than ligation. Corneal damage. When I started doing tubes, a couple of people said, you know, after 10 years, the corneas all fail. And many corneal specialists will say that they cause corneal decompensation. Studies actually don't demonstrate this clearly. Most tubes do not cause decompensation during the 5 years of the longest prospective studies. Very long-term studies in the past have not reported the risk of corneal failure. Most corneal specialists only see the ones that fail. And when you're stuck, it's easier to replace the cornea than the optic nerve, though obviously you don't want to damage the cornea. So if your tube's right against the cornea, obviously that's bad news. If you have a long tube, though, and lowish pressure, if you actually achieve high single-figure pressures and you have a long tube, when the patient rubs their eye, the tube moves all over the place. So it can damage the cornea even if it's away from it. So these are things to be kept in mind. Tube in the AC should be parallel to the iris plane. This one is pointing up towards the cornea. And I think you've got to be careful when you put a tube in, put it in get the eye into the primary position so the tube is not pointing upwards towards the cornea. And I found in my practice, the fellows tend to put the superior tubes up pointing towards the cornea, and the inferior tubes, when they go down below, they tend to dip down towards the iris, and it's because they're not putting them in the primary position when they implant them. This is what on first inspection externally looks like a well-placed tube, but in fact you can see the entry site is way in front of scleral spur. This tube is in the cornea. It's as simple as that, and it's a black hole for endothelium. And Paul Pamberg doesn't remember it, but that's what he said a long time ago, that it acts like a black hole for endothelial cells, and it does. If it tubes in the peripheral cornea, you're damaging the endothelium at the entry site with the tube movement. Others have blamed inflammation, eddy currents, whatever. We published a 5-year prospective study on Barvelt position, inflammation, IOP, etc., and endothelial cell count in ophthalmology glaucoma 4 years ago. We found that endothelial cell density centrally decreased by 37% in 5 years, and over the tube in the periphery it was by 50%. However, this is not the whole story. If you looked at the tube entry site position, where the insertion position at the entry site, if it was all of the tube was in front of Swalby's line, that half the endothelial cell loss. If the tube was straddling Swalby's line, which to be honest is where most people put it, you get twice the endothelial cell loss rate. and the other positions were intermediary. Now, that you see that it's getting double endothelial cell loss rate. What puzzled me was that when it's behind Schwalbe's line, you're still losing endothelium. And half of these patients were uveitic, and we measured the flare on everyone, and uveitis and flare had no influence. Now, Ying Han at UCSF published this last year, a couple of years ago, of endothelial cell loss with amide valves in the AC versus sulcus. And in the sulcus, you're still getting a similar rate to endothelial cell loss behind Schwalbe's line. So it's not any better. It's better than randomly placing it in the AC, but it's not better than having it flat on the iris. So this is obviously a factor. So people worry about the tip, but actually the insertion position is important as well. Here's a case that I saw recently referred in, and this patient had a clear cornea apart from an opacity over the tip, and this is obviously of concern because although the tube position looked okay, it was obviously moving against the cornea. You can see the position is not that bad, but when I rubbed the eye, the tube moved back and forward. Why do many not decompensate? Well, you imagine if you start with an endothelial cell count of 2,000 and with a 25% loss, and the optimum really, after 5 years, you're going to have 1,500. After 10 years, you're going to have 1,125. After 15 years, you're going to have 843. After 20 years, you're going to have 632. So if with an optimum tube positioning, you're going to have corneal failure after 25 years. But if you put it where a lot of people put it, straddling Schwalbe's line, after 5 years at 50% loss, you're going to have 1,000. After 10 years, you're going to fail. So if you don't put it flat against the iris or in the sulcus, you're going to fail instead in 10 years. So this patient had upper double plate Maltino in the 1990s and an infratemporal Barvelt in 2002. And this video was taken in 2022, and the cornea is as clear as a whistle. And this patient's got double trouble, yet after 20 years after the Barvelt, and much more than 20 years after the Maltino, the cornea is still clear. So it's not inevitable that the corneas die, and entry site position is important. So around 50% of tube-related endothelial cell loss is mechanical. Flare does not seem to have a major role. It also seems to be independent of IOP, although obviously we've got very high pressures that which we didn't largely have in the study, that probably is damaging the pressure. But logically, a smaller tube, largely the problem is that the tubes are too big, and a smaller tube should help. The pole glaucoma implant is 2/3 the diameter tube of a Barvelt, and it's slightly larger than a PreserFlow. And you would think that that would hopefully reduce endothelial cell loss and reduce erosion rate, but this remains to be proven. And you can see the pole there in profile compared with the Barvelt and PreserFlow. What about erosion? Well, erosion's a pain, and we obviously patch tubes to prevent it. Obviously a long and winding tube's not such a good idea. It's a non-linear course is not good. Ideally, you want to have a straight, short course, as little tube on the external part of the eye as possible. One of our ex-fellows at Corrado Gizzi did a retrospective study of 76 tubes at Moorfields. There's a 45% risk of re-erosion in 4 years. And this was reduced by repositioning more posteriorly and using a patch graft other than pericardium. Pericardium seems to vanish. The other patch grafts used were cornea, sclera, and pseudoplast fascia lata. And pseudoplast fascia lata seems pretty robust, and it comes in a packet like pseudoplast pericardium. But repositioning, if a tube erodes, you've got to think, is it in an ideal position? And generally putting it more posteriorly means a more shorter external course. And this is just a very rapid video of one tube that I repositioned. And you could see they always have conjunctiva stuck down around them. And it depends on degree. And that's just a piece of fascia lata using to bung the hole. It's much easier to bung holes than to suture them. And you glue it down, tube in the new entry site, and the new entry site is more posterior, and the tube's flat on the iris or close to it. Suture it down, more fascia lata glued, and then the conjunctiva closed. Conjunctival mobilization is very important because I never see an erosion that doesn't have conjunctiva stuck down around it, although it's hard to know whether it's the chicken or the egg. So retraction and obstruction, you know, this is not an aphakic eye, the tube and a PI. You can see there's vitreous blocking it, which is and obviously you've got to go back and withdraw get the vitreous out of it. If a tube, although I tell people to put the tubes on the iris, you mustn't put them in the iris, or this can happen. If this does happen, an easy fix is to flip it out at the slit lamp, but there's always a risk of reocclusion. This patient had a bad cataract, so was able to flip the tube out at the slit lamp, but then we went ahead later and did the cataract surgery, but the pressure was 40 when the tube was obstructed. When I flipped it out, it came down to high single figures, and it stayed there until we got the cataract out, and then the AC was deeper and the tube didn't re-obstruct. Sulcus placement is great, especially if there's an iridectomy, but there are some people nowadays saying to do blind sulcus fixation, and I don't think that's a good idea. If you've got a fixed pupil, it's reasonable to leave it in the pupil, and people agonize about putting tubes on a phakic lens, and to be quite honest, I don't see a problem. It's not like vitrectomy and gas where you get cataract within a year. Tube lens touch doesn't actually cause dramatic cataracts. You'll often get a little bit of opacification around the capsule, and it's certainly better than putting it in the cornea. But blind sulcus fixation is a bad idea. Here is one. The iris sucked into the tube. And what's going on? They just put the tube in the eye. I don't think it was reverse beveled. And this is it on ultrasound. The problem is that this iris was sucked into the tube and the patient had a high pressure, but it was also badly placed encapsulated Maltino that was 3 millimeters from the limbus, which is obviously not a great idea either. So was the pressure high because the iris was in the tube or because it was encapsulated? Well, you don't know until you unblock it. And when we unblocked it, we found the reason the iris got deflected into the tube was this big sommering ring underneath. So if you're doing blind sulcus fixation, you don't know where the tube's going. And you can, although I've taken the video out here, I've seen several over the years where the tube ends up in the vitreous cavity because it was implanted when nobody could see where it was going. So what happens is you go into the sulcus blindly, you hit the edge of the lens, the zonule, and the tube goes back into the vitreous and blocks. Easy fix for sulcus fixation, if you don't have a PI, is doing a PI with vitrectomy scissors and forceps. Why? Because it maintains clarity of view. You can see where the tube is and you can see what you're doing. If you require extra length, such as this retracted tube, which has got iris against the cornea as well, so there's really nowhere to put it, then you need some way of extending it. Now, if you put a tube in obliquely, firstly, you can put it at 12 o'clock obliquely. That maximizes lid coverage. It reduces the bend in the tube at the entry site, minimizing dolphining. And if you need to move it later, you've got a bit of extra length. So an oblique tube's not a bad idea for producing extra length. And if it's a corneal graft and you've got an oblique tube, then you're keeping it behind the host and not behind the donor, which is probably also a good idea. If you do need to extend, the Amid extender can be used to extend a Barvelt, an Amid, or a Molteno, but they have a very high erosion rate because of this large pleats of plastic close to the limbus. So we don't really like the Amid extender for that reason, although it is useful if you're stuck. The important thing about the Amid, and you can see this is an ancient video because I haven't done one of these for about 15 years. The important thing with the Amid extender is to amputate the tube near the plate so you can keep the plate, the part of the extender, away from the limbus so that it doesn't erode. You still need a little bit of tube on the plate so that you can actually attach it, but it stops it eroding if you've got it further from the limbus. Now, this tube was referred by a colleague. They had early hypotony, and unusually there was a hole in the tube, but unusually this hole in the tube was causing bad hypotony. And typically, if you want to extend a barbelt nowadays at Moorfield, we'll use a pressure flow and just stick it on the end of it. So that's a piece of donor sclera going into the old entry site, and the tube's being, and a pressure flow is being attached to it. You've got to make sure that's snug and stitch it down tightly. And then that's some glue just to over the bung and stitch it all down and make sure the join is secure. And that, yeah, there's no more leakage. Now, what happens if you've got a retracted Paul implant? Well, this one retracted dramatically, and it'll also second time movement. It had moved, so I didn't want to do it again. So how do you extend a Paul? Well, we can't extend it with a pressure flow, but we can extend it with a piece of barvelt. It's a very tight squeeze, but you can put a piece of barvelt over a Paul implant. As I say, the join is very tight. And I was worried it might be occluding the tube completely, but with injecting Vision Blue up it, I could see it was still patent, and put it back in the eye. And in fact, I've got a follow-up video that shows that after, in a second, you can see it goes back in the eye. You've got to, again, secure the entry site tightly, secure the junction tightly. It's in an iridectomy, so you can see the tip. And after, mercifully, after 6 months, it hasn't slipped or fallen or anything. And I've got the 4-week video in a second. Yeah, that was at 4 weeks, but that was, sorry, 1 day. And that was at 4 weeks, but I've also got a 6-month one, and it was fine. Diplopia is random and difficult to predict. I don't personally think it's anything to do with the muscles. I think it's all to do with the bulk of the implant in a tight orbit and a combination of that and adhesions. Why do I think that? Because I actually explored a few, and when patients have got really bad diplopia, I've actually gone back in and freed up adhesions and actually found that released it. Because when I've gone back and looked, there's never really been anything visibly wrong with the muscles. And it was Paul Pamberg who used to always say, put the plate 1 millimeter or 2 back, so it's not up against the muscles, and that's what I tend to do. Anyway, that's about it. Thank you very much for your attention.
Thank you, Dr. Keith, for wonderfully covering up the most important complications of the tube surgery and sparing your time from the busy schedule. I would request Dr. Tanuj to ask any questions pertaining to the talk or give his insights.
So Keith, thank you. It was such a nice learning experience to hear you. So Keith, one of the problems that we face, we have been using a lot of the Ahmed glaucoma valve, is the encapsulated blebs around the tube and very high pressure. So how do you manage if there is a tube encapsulation and high pressure?
Oh yeah, with Ahmed valve, I take it out and put in a barvelt.
So
I just don't use Ahmeds. I mean, I've used them over the years, but they just encapsulate too much. Yeah, I mean, the longer answer to that is, if I see an encapsulated Ahmed, if it's got a big bleb, then it's probably doing something. So it'd be aqueous suppressants, but I'd often end up then putting a barvelt somewhere else. A more common scenario is I see these shrink-wrapped Ahmeds where it's literally just the tissues have clung down over it. And then I just remove the thing because it's not doing anything.
And Keith, what is your experience for the tube erosions? A number of surgeons don't use a scleral patch graft. They use a long intrascleral tunnel and put in the tube in the anterior chamber. So vis-a-vis using a scleral patch graft over the tube versus intrascleral without patch graft. So what is your experience?
The answer is I don't know, because we've always used a patch graft. The tunnel is very elegant. My only concern about tunnels is making sure you get the tube in the right place in the anterior chamber, because it's more difficult to get the tube flat on the iris. And it's more likely to end up in the cornea if you don't have control at the entry site. Now, people do tunnels in different ways. Some people do a double tunnel, so then they do have a chance at the entry site to get it in right. But if you have a long tunnel and nothing else, then it's like putting in a pressure flow. It's hard to get it exactly where you want in the AC. And
Keith,
that's bad for the cornea.
Keith, can I interrupt for a second? We've found that if you make a little groove at the entry site of the tube for this long tunnel and hold on to that and be pulling the globe up to the primary position, which you made a really good point about.
Yeah.
When you enter, you have that control to see You're looking perpendicularly down on the iris to see that it's just right over the iris. So that, rather than using fixation sutures, using a little groove about 1/3 thickness, holding onto the forceps and rotating the globe up against the needle, you're actually pulling the globe up and impaling it on the needle. You have
No,
much better
I agree.
control.
You know, it is possible, but it's difficult, and people don't, in general, pay so much attention to the tube entry position. So, which is why tubes got a bad reputation for damaging the cornea, and it's just one more thing.
It's critical. You're right. The one
Yeah.
other thing I should mention is if you use my trab technique of putting mitomycin through the intermuscular septum, and then you put a barbelt in there, and if you then get severe hypotony when the suture melts, the vicryl around the tube, if that's how you close it off.
No, wait. This is why I don't use a vicryl.
Then I take it out. I took it out and put in an Ahmed. If it was not going to form a capsule, then you could just substitute an Ahmed for the barbelt, and it ended up with a pressure 12. It was great. But
Sure. The problem is that the mito problem from the vicryl is at 5 weeks, whereas they still, with the mito, they still heal, but it takes 3 months. So you don't know at 5 weeks if you're going to get chronic hypotony or not. It's too early. That's the problem. So if you're swapping out an Ahmed, you might be taking out a barbelt that would be working perfectly in 3 or 4 months.
I'm talking about a flat chamber with a tube against the cornea and a pressure of 0.
Yeah, no, but that's because you're using that's why we haven't used the vicryl for 20 years here.
Okay.
I mean, that went out as soon as we started using mitomycin.
Thank you, Dr. Keith. And now,
thanks so much. Got to run.
Thank you. And I would be happy if you can re-log in again for this webinar. And now I invite our next speaker, Dr. Benjamin Zhu. Dr. Benjamin, let me introduce you first. Can you stop sharing your screen? Yeah, just.
Sorry about that.
Yeah, so Dr. Benjamin, he's an associate professor of clinical ophthalmology, chief of glaucoma services, director data science and AI core at USC Roski Eye Institute, King School of Medicine. His research focuses on developing new diagnostic tools to detect and care for patients with angle closure using AIOSSC imaging and AI. He also studies the impact of PACG on patient population and healthcare systems worldwide using epidemiological and electronic healthcare data. So over to you, Dr. Benjamin. I know all of you are taking out your time from the busy schedule of starting of the day. So over to you, Dr. Benjamin. Yeah, we can see your slides.
Okay, perfect. Great. Good evening, everyone. It's a real pleasure to be here with all of you today. I'd like to thank Dr. Porwal for the kind invitation to speak today. Before I begin, I'd just like to announce my financial disclosures. I do receive research support from the NIH and Glaucoma Research Foundation, and I receive research support from Heidelberg Engineering as well, and I will be talking about their anterior segment OCT imaging system. We know that primary angle closure glaucoma is a common cause of permanent vision loss worldwide. It currently affects around 24 million people, with 3/4 of those cases occurring in Asian regions. The prevalence of PACG is rising rapidly, primarily due to an aging population, and this rise in PACG prevalence is concerning, as we know that PACG is more visually damaging than POAG. Gonioscopy remains the current clinical standard for evaluating the angle to detect at-risk patients, and the key structure to identify in gonioscopy is the pigmented trabecular meshwork. When we can't visualize this structure, we tell patients that they have angle closure and may be at risk for PACG. Angle closure detected on gonioscopy forms the basis of current definitions of primary angle closure disease. Primary angle closure suspect, or PACS, is the mildest form in which there are 2 or more quadrants of angle closure on gonioscopy, and this is generally thought to be a low-risk state for PACG. Primary angle closure, or PAC, is the next stage in which there is also formation of PAS, or elevated IOP, and this is a higher risk state for PACG. And finally, PACG is diagnosed in the presence of glaucomatous optic nerve damage with or without visual field defects. The benefits of intervention in PAC and PACG eyes is clear. For example, the landmark EAGLE trial found that both LPI and lens extraction produce robust IOP lowering in angle closure eyes with either high IOP or glaucoma. We also know that these two treatments can break pupillary block and therefore are treatments for acute angle closure attacks. These clear benefits have led to a consensus by both the World Glaucoma Association as well as the American Academy of Ophthalmology. Both bodies recommend treatment in eyes with PAC and PACG. However, based on epidemiological studies, such as the Lee-1 eye study, we know that the majority of PACD worldwide is mild in the form of PACS. Therefore, an important question that arises is, what is the benefit of treating PACS eyes? This was the topic of study for the Zhongshan Angle Closure Prevention Trial, or the ZAP trial. This was a landmark study published in The Lancet in 2019 that assessed the benefit of LPI for the prevention of angle closure. The ZAP trial recruited 889 bilateral primary angle closure suspects. They were all between ages 50 to 70 and were mainland Chinese. These participants received LPI in one eye and were monitored in the other eye. Participants were followed for up to 6 years, and the endpoint was progression to primary angle closure, defined as the development of PAS, IOP over 24 millimeters of mercury, or an acute primary angle closure attack. The ZAP trial yielded two primary findings. First, LPI was effective in reducing the risk of angle closure progression by around 50%. However, the other primary finding is that the risk of progression in untreated eyes was low at only 0.8% per eye year. This led the ZAP authors to conclude that efforts to identify and treat with iridotomy on a population basis probably are not the best use of resources. Therefore, an important question is, which PACS eyes are at higher risk for PACG and should receive earlier treatment, at least those that do not have visually significant cataracts? The most intuitive answer to this question are the fellow eyes of eyes that have already developed PAC or PACG. We've known for a long time that eyes that have experienced acute angle closure attacks, the fellow eye is also at high risk of an acute attack, even within a short period of time. And so these eyes should certainly warrant prompt treatment. Family history is also another important risk factor for more severe angle closure disease. This is a study that was conducted in South India. And here, participants or patients with PAC or PACG with siblings, amongst those siblings, 11.4% had PAC or PACG themselves, which indicates the strong familial risk of PACG. Age, we know, is an important risk factor for more severe angle closure disease. This meta-analysis shows the rising prevalence of PACG with each decade of life, both in men and in women, suggesting that older participants are at higher risk. What about patients who receive frequent dilation? Here, the data is perhaps a bit more mixed. In the ZAP trial, there were 6 total episodes of acute primary angle closure, and 4 of those 6 occurred after dilation. However, it's important to know that there were thousands of dilations performed during ZAP, and the cumulative risk here was less than 1 in 1,000 per eye year. Other studies have corroborated this finding and have reported low risk of acute primary angle closure and IOP elevation after dilation, even in eyes with angle closure. And so this low risk likely extends to other medications with weak anticholinergic effects, such as antihistamines and antidepressants. Recent work by our lab and many others have indicated that ocular biometrics may help risk stratify PACS eyes. We live in the era of anterior segment OCT, which is a convenient alternative to gonioscopy for evaluating the anterior chamber. Here we can see this beautiful high-resolution image of the cornea, iris, lens, as well as the anterior chamber angle. And these images can be acquired in mere seconds without need for contact with our patient's eyes. These images can be assessed quantitatively after the cornea, iris, and lens have been segmented and the scleral spurs have been identified. We can obtain measurements of various biometric parameters that describe the size, shape, and configuration of the anterior segment and its anatomical structures. For the first 7 years or so of my career, I tried to study the clinical implications of these biometric measurements. This is a paper that we published in 2018 using data from the population-based Chinese American eye study conducted here in Los Angeles. In this study, we looked at the correlation between intraocular pressure and angle configuration measured by OCT. Our measure of angle width here was the trabecular iris space area, or TISA. This plot shows our primary findings. On the y-axis is intraocular pressure, and on the x-axis are measurements of TISA. We see that for patients with wider open angles, who are represented on the right, there is effectively no correlation between the two. However, below a specific cutoff, a strong and significant negative correlation emerges. This plot would suggest that patients' risk for elevated IOP increases as measurements of angle width decrease. More recently, I've collaborated with the authors of the ZAP trial in order to assess ocular biometric risk factors for progression of primary angle closure disease. In this study, we only took data from untreated eyes so we could study the natural history of angle closure disease. And these participants had all received gonioscopy and ASOCT at baseline. My primary outcome measure was progression from PACS to PAC. This table summarizes the baseline demographic and biometric differences between non-progressors and progressors. We see here that progressors tended to have significantly higher IOP at baseline. However, there was no difference in cumulative gonioscopy score, which is a sum of the gonioscopy grades across the 4 quadrants. Conversely, measurements of angle width obtained using ASOCT, including angle opening distance, or AOD, and trabecular iris space area, or TISA, were significantly different between progressors and non-progressors, with progressors having narrow angles at baseline. Progressors also tended to have smaller iris area as well as flatter iris curvature. Next, we developed multivariable models assessing predictors of progression. In this model, our measure of angle width was angle opening distance, or AOD 500. And here you can see, adjusted for age, iris curvature, and ACD, that AOD was significantly associated with progression risk. For every 10 microns smaller in AOD, the odds of progression increased by around 10%. Next, we replaced AOD with cumulative gonioscopy score as our measure of angle width. And here we can see that gonioscopy score was not associated with risk of progression. This provides evidence that ASOCT yields information about angle closure progression risk that is not available using conventional angle assessments by gonioscopy. So in summary, treatment does not appear to be beneficial for the majority of PACS eyes, at least those without visually significant cataracts. Patient history can help us identify high-risk cases. And hopefully in the future, ocular biometrics, which are associated with angle closure severity and progression, can also help us identify patients who could benefit from earlier treatment. However, we do need additional longitudinal studies in diverse populations before we can adopt ASOCT imaging into our routine care of angle closure patients. I'd just like to acknowledge the hard work and contributions of all of my lab members. And if you're interested in receiving updates about angle closure research, I invite you to follow us on Twitter/X. And finally, I'd just like to invite everybody to the World Glaucoma Congress next year in Hawaii. Thank you very much for your attention. It's wonderful to be here.
Thank you, Dr. Benjamin, for the wonderful insight on the angle closure PACS. I've heard you before also, and your work and your publications on this topic is tremendous. I would like Dr. Chandrima to ask a comment about this talk. Can you stop sharing the screen, Dr. Benjamin?
Yes.
So wonderful talk, Dr. Benjamin, as usual. So I'd like to ask you that, say, in a middle-aged individual who has a high lens vault, when you see on the AIOSSC, and of course with angle closure, and angle closure suspect, IOP is within normal limits. So would you advocate capsular iridotomy, or would you advocate a clear lens extraction?
Yeah, so that's a really good question. Clear lens extraction, I think, is always a hard sell, especially in younger patients who may still have some accommodation left. Now, the rare exception would be somebody who is a high hyperope, who might derive a refractive benefit. But certainly, I think there is still a role for LPI in those cases, particularly in patients who might be more resistant to having clear lens extraction. When the lens is that far forward in the eye, there's almost always a component of pupillary block. And so I don't think that it is something that should not be considered, especially when there is no visually significant cataract.
Right. So with a high lens vault and a PACS, you would advocate a clear lens extraction. And nowadays,
I think, again, I think this requires a conversation with the patient, and a little bit more information about the specific patient would be required. Even though we know that clear lens extraction would be the most definitive treatment in this case, clearly patients who don't derive a refractive benefit may end up unhappy if they're not seeing as well as they used to, if they lose any sort of accommodation, and they're not deriving any sort of IOP benefit, as would be the case here.
So with the clear lens extraction, we nowadays have the EDOF IOLs. So what is your opinion on using the EDOF IOLs in such a patient who is
No. I think it's fantastic. Certainly if the patient doesn't have any glaucomatous damage and is at high risk for angle closure progression, it's better to take out the lens early and then replace it with something where the patient might have some near vision. I didn't have a chance to mention that we have an ongoing NIH-funded study here called the Multiracial Angle Closure Progression Study, where we're testing specific ASOCT cutoffs in terms of angle width to identify the progression risk. And so hopefully in the future, we'll just need to take a quick ASOCT image, and then we'll know the risk. And depending on the level of risk, we can advise patients to receive more invasive treatments like clear lens extraction.
Wonderful. So we look forward to the results of that study. Thank you very much.
Thank you.
Dr. Tanuj, any comment from your side?
Benjamin, thanks. Excellent lecture. Just one, we often face diabetics with primary angle closure suspects. So what is your advice for that group? Because they have to come
diabetics.
Dilated examinations.
Yeah, so I presented a little bit of the data on dilation, and we're actually conducting a series of studies right now to try to raise awareness that dilation in the general population is very, very safe. And even in PACS eyes, dilation is very safe, as evidenced by results from the ZAP trial, as well as other smaller studies. My general sense is that if patients need to be dilated, they should be dilated, because this is kind of a stress test for the eye itself. Of course, patients should be educated about the symptoms of acute angle closure, but it's better for patients to know and for this to be caught early and patients to be treated than to wait until the disease may creep in a more indolent fashion. Dilation is also a big issue because of the rise of teleophthalmology, teleretinal screening for diseases. The inability to dilate people results in a loss of about 20% of images. So I think in the future, we need to get comfortable with this idea of dilating people, even if they don't receive gonioscopy, but also providing people with precautions as well.
And what is your regimen for follow-up? Once you see a PACS and you tell him that nothing needs to be done, then what is your protocol for follow-up lifelong?
Yeah. So currently, I've extended the monitoring out to 1 year. But as I said, we have this ongoing study, and that's the issue with gonioscopy, which is that patients are either occludable or they're not occludable. They either have PAS and elevated IOP and they're already PAC, or they're just PAS, and that's a big bucket. And so I think in the near future, we'll be shifting to using AIOSSC to risk stratify our PACS patients so that we can at least come up with better monitoring schedules rather than just have everybody come at the same interval.
And you are using only the nasal temporal angles for the measurements. So won't that be a bit inadequate because you have a 360-degree angle and you are taking just 2 points of measurement?
Yeah, that's a great question. I didn't mention this when I showed the ZAP data, but we actually did look at the predictive value of the vertical measurements as well. And what we found is that those were not as predictive, perhaps because the superior part of the angle was already the most commonly narrow. And so the predictive information was much more robust along that horizontal meridian, which is actually very, very convenient because that's the easiest meridian to obtain imaging data from. And retracting the eyelids in some patients can be very difficult. So I think in this case, we got very fortunate, and perhaps we can get away with just taking a horizontal scan or having information that is contained within the palpebral fissure.
Thank you, Benjamin.
Thank you very much.
Thank you for the wonderful insight and the wonderful talk. And I'll now invite our next speaker, Dr. Noel Chan. So Dr. Noel Chan is the consultant at the Department of Ophthalmology and Visual Sciences, Prince of Wales and Alice Home Link, Nethersole Hospitals, New Territories, East Cluster Hospital Authority, Hong Kong. She is the Secretary for Ophthalmic Education Standing Committee at the APU. Dr. Chan's major research area focuses on glaucoma, in particular angle closure glaucoma and normal tension glaucoma, optic neuropathies and ocular imaging. She has numerous publications in peer-reviewed journals and has multiple book chapters. So over to you, Dr. Noel.
Hello, everyone. Let me share my slides. So is everyone seeing my slides?
I can see your slides. I can hear you.
Thank you very much. So first of all, I'd like to thank Dr. Amit Powell and Professor Namrata Sharma and the committee for inviting me over to speak to everyone here. And to follow all these glaucoma giants is such an honor and privilege to share with you guys. And I think the only edge that I'm having here is that I'm both a glaucomatologist as well as a neuro-ophthalmologist. And I'd also like to take this opportunity to thank my mentor, Professor Carmen Chen, and also one of the speakers here, Chris, who has written a book chapter, particularly on this topic. So today we are going to go through some of the glaucoma masqueraders, and as the in my viewpoints as a neuro-ophthalmologist. So when we are teaching our residents, we always start off with discussing how a visual field defect is going to look like in glaucoma patients. So they typically comes with supra- infranasal defects, which extends into an arcuate defects following the horizontal midlines. And later on in the later stage, they will go through a tunnel vision and with a very small temporal island at the late stage. However, we might not have discussed it with them that there are a lot of other non-glaucoma patients who will share similar visual field defects. And here are some of the possibilities that are sharing these type of visual field defects that you might need to think about before you even start diagnosing your patients with glaucoma. So they come with glaucoma, congenital disc anomalies, different types of them, retinal diseases, optic neuropathies, and even brain diseases. So I think most of our general ophthalmologists as well as our glaucomatologists here are facing a lot of referrals whom we are given with large disc with increased cup disc ratio. And these are maculopapular patients. Sometimes they are referred to us because of asymmetrical cup disc ratio because unilateral variant is possible. They are very easy to be distinguished from glaucoma patients because they have no retinal nerve fiber layer thinning on our OCT and they have normal visual fields. And so we easily discharge these patients. And sometimes we get these type of discs where we have large discs, radially oriented blood vessels with sometimes an annular PPA and but not commonly, we may encounter an emanating tuft of glial tissue. This group of patients typically come with us with an enlarged blind spot, which might be mistaken by some of our residents as central cecal scotoma. But with the experience, we know that this is just morning glory syndrome. And I would say that these type of congenital anomalies are very easy to be distinguished from glaucoma patients. How about this one? These visual fields are shared between these two appearances, but then only one of them is glaucoma. Is it the one on the left or is it the one on the right? The answer is that the one on the right-hand side is glaucoma, while for the left-hand side, if you take a closer look, you'll be able to see that there is an inferior excavation of the disc where the vessel, in fact, originates from the periphery, giving rise to this superior arcuate defect. So, in fact, this is just an optic disc coloboma. Similar to an optic disc coloboma, over the disc over the right-hand side, you will be able to see that there's a small slit over the inferior part of the disc, and both of these anomalies is going to give rise to an focal retinal nerve fiber layer defect over the inferior part, and they come with a superior arcuate defect, which is very similar to a glaucoma patient's. For the optic disc patients, you might even sometimes encounter a progressive visual field loss if it is associated with neurosensory detachment. So I would say that optic disc coloboma and optic disc pits are very strong glaucoma masqueraders that you need to look at. So one may say that, so how about inferior visual field defects? Are they safe then? In fact, this is the visual field defect of this patient's optic disc. You'll be able to see that their central retinal artery has a superior entrance and that there is a superior disc pallor accompanying a peripapillary halo. And when you did OCT for this patient, you will see that there's a focal superior RNFL thinning. So is this glaucoma? Unfortunately, no. This is a superior segmental optic nerve hypoplasia, which is a congenital developmental anomaly, which is associated with gestational diabetes. So there are so many types of different congenital disc anomalies which can mimic glaucoma. So how can we tell? First, unfortunately, we still need to look at our disc, even though we have our OCT machines. So be careful and be sure that you have to examine your disc, particularly at the time of diagnosis. Secondly, most of these visual field defects will not progress as time goes by, except for PIT, which sometimes associated with neurosensory detachment of that retinal layer that will give rise to progressive visual field loss. And it is important that you monitor them with clinical disc photo because sometimes you might have difficulty examining them under your 90D. So here's another case that I would like to share with you. This is a patient referred to me with a very good visual acuity of 0.7, a high myope patient with a pressure of 19 bilaterally. The cup-disc ratio is 0.8 and the frontal examination is normal. He was being seen by a general ophthalmologist and being started on Timolol. So you can see that the bilateral visual fields are constricted. So probably this is glaucoma, is it? But then we did an OCT for this patient. At that time, it was still the first generation machine. As you can see, the RNFL is lost, but then it looks weird to me. As you can see, the pattern doesn't actually correlate very nicely with the visual field. The RNFL is quite strong. So we did a full field ELG for this patient, and you can see a flat, dark adapted and light adapted ELG. And in fact, this patient has retinitis pigmentosa sine pigmento. That means that even on fundal examinations, you are not going to see any pigments. So this is why the patients have the visual field defects. So it is important for us to remember that a lot of other retinal causes can give rise to visual field loss. RP can sometimes be having no pigments to be picked up on your retinal examination, and they can be sectoral in origin, some like sectoral RP, giving rise to this type of superior arcuate defects. Patients with previous history of BRAO and BRVO can have arcuate defects and even cannot be distinguished using OCT. Patients with retinal schisis can have visual field defects mimicking in glaucoma as well. So beware that you have to dilate the patient's pupil and examine the fundi before you make your diagnosis. So during the history taking, be very careful to ask for any visual loss in the past. And during your examination, you might want to look for any sclerosed vessel or disc collaterals. And the hint over there is the discordant RNFL and visual field. So beware of the outer retina and photoretinal diseases. And sometimes, like our first case, we might need electrodiagnostic tests in order to make the diagnosis. How about other optic neuropathies? There are a whole bunch of optic neuropathies which can give rise to visual field defects. After all, glaucoma is an optic nerve problem, and this is just a kind of optic neuropathies. So let's go through some of the hereditary optic neuropathies, one of which is Leber's. Elhorn, which is Leber's hereditary optic neuropathy. They usually present with an acute visual loss, which is consecutive in nature. They can give rise to central glaucoma. And I would say that this is an easy fix because you will find this patients presenting acutely, which is very uncommon to be misdiagnosed as a glaucoma. How about dominant optic atrophy? They also give rise to central glaucomas and sometimes bearing the peripheral field, and they can be mimickers for glaucoma. Why? Because they commonly associated with increased cup-disc ratio, and usually they're incidentally found. That means they don't present to you until you found them. And they can have slow visual field progression with time as well. And you might be sometimes being mistaken to be having a central glaucoma in NTG patients. And so sometimes these patients actually do have just autosomal dominant optic atrophy. So how can we tell them apart? First of all, take a family history. You might even sometimes want to examine their siblings, particularly if they have a family history of glaucoma. And the second hint is that usually autosomal dominant optic atrophy patients will have temporal RNFL loss, and if you have careful examination of the disc, you'll be able to see a temporal pallor. However, in order to make a definite diagnosis, you need a genetic testing of OPA1 gene. How about toxic and nutritional optic neuropathies? The most common one would be B12 and folate deficiency. And if the patient has previous history of TB and the use of some of these medications, they can also present with central glaucoma. And they can be mimickers of glaucoma because they are slow in onset and can be progressive in nature. And more importantly, they can overlap with our true glaucoma patients. I have had patients who are having both glaucoma and these type of B12 and folate deficiency. So sometimes when your patient progress, do think about these as well. So make sure that you do a careful history taking, particularly asking for their diets and whether they are specifically doing some of the recent particular omission of some types of vegetables. And usually for these type of generalized, these type of nutritional optic neuropathies or toxic neuropathies, you encounter a more generalized RNFL loss. So particularly look at the nasal sector over your OCT that can be affected, which is unlike most of the glaucoma where the nasal sector will be spared in most of the time. So sometimes you may just need to do a lab test for the B12 and folate in order to make such a diagnosis. How about optic neuritis? For the acute one, again, it is an easy call because they will have a central loss, diffuse loss, and they typically present acutely with a drop in vision. However, it might be difficult if they are of a chronic stage. That means they're in a recover stage. That means they have recovered from their previous history of optic neuritis, leaving behind a partial arcuate defect or paracentral defects. So how to tell? Apart from taking a history, I find clinical examination using color vision very useful because most of these patients who have had previous history of optic neuritis will persistently have a poorer color vision. And also examination of the disc may let you know that there's some sort of sectoral pallor. And again, the correlation between the RNFL and visual field loss is very important, that you will notice that the visual field is much better than your OCT. That means they will have a more generalized RNFL loss, while the visual field will just have a small defects. The visual field OCT correlation is very important here. Here is one of the two patients. Again, one is glaucoma and one is not. One is having an other type of optic neuropathy. So you will see that in fact, they just completely look the same. In fact, one of the patients is having non-arteritic ischemic optic neuropathies. So for Arteritic anterior ischemic optic neuropathy, it is very easy to distinguish from glaucoma as it can give rise to extensive diffuse visual field defects and a very poor vision. However, for the non-arteritic one, which is one of the most common optic neuropathies you will encounter, they typically give rise to altitudinal inferior or superior defects and sometimes arcuate defects. That is giving rise a very hard time for us to distinguish. So first of all, they are the most common type of neuropathies. Secondly, they can be bilateral. The previous clinical examination using color vision might not work here because NARN typically have a very good color vision, especially when they're in the recover stage. And they can have increased cup-disc ratio with time. Our group has previously published that their cup-disc ratio increases to up to 0.5 or 0.6 as time goes by, and they will have a sectoral RNFL thinning picked up on the OCT. And they do have visual field progression in the early phase. So how do we tell them apart? In fact, first of all, you might be able to take a history of an acute visual loss in the past. However, I find examining the contralateral eye more important. That means the contralateral eye might have this at risk. And over this, you might be able to appreciate that there's a sectoral pallor, which respects the horizontal meridian over this eye. And if you follow them long enough, usually at the later stage, their visual field loss will stabilize and no longer progresses. So here is another case which is referred to me for bilateral glaucoma and to consider trabeculectomy. He has been followed by a general ophthalmologist for 1 year and again with a family history of glaucoma. The baseline and maximum pressure were not given to me, and he was already being put on quite a number of medications. And on examination, in fact, the bilateral visual acuity is 0.5, which is not that good. The refraction, again, in our locality, unfortunately, we have a lot of high myop patients. While on medications, his pressure seems fine, but then the visual field just looked odd to me. How come the visual field is that bad, I would say? So I did an MRI, and in fact, eventually the MRI comes back to have a right compressive optic neuropathy due to the orbital apex tumor. So here comes to other type of things that you might need to be aware of when you're diagnosing glaucoma. It can be tumors of different types or even strokes. So here's another case. Our patients come to me with a vision, this time very good, 1.0. The pressure is low, and it is a low mild patient. However, the cup-disc ratio is a bit large, like 0.6 to 0.7 with PPA. This is the OCT of the patients. You can see that there's a retinal fiber layer thinning, particularly over the left side, although there's some red diseases. And on the GCIPL, you'll be able to see that there's some loss. However, the visual field is quite full. So is this a pre-perimetric glaucoma, or is it a myopia-related thing? So this is the visual field of the patient. So when I asked the patient's further history, in fact, he tell me that, in fact, he has a large pituitary tumor compressing to his optic chiasm, and he had done a excision almost 10 years ago. And this is the visual field back then, which gives rise to the bitemporal visual field loss. As you can see that the bitemporal visual field loss can be absent and disappeared after a good surgery. So it is very important to take a history. Otherwise, even a new set of MRI will not give you an answer here, okay? And so be very highly suspicious of any compressive optic neuropathy, which is the greatest mimicker of our glaucoma patients. So what kind of tumors am I looking for? First of all, suprasellar tumors, either pituitary adenomas, craniopharyngiomas, or sellar meningiomas. And in our first case, remember, you can sometimes have orbital apex tumor, particularly looking for cavernous hemangiomas. Optic nerve shift meningiomas can also mimic a glaucoma patients, as they can wrap around our optic nerve and give rise to progressive visual field loss. And depending on the location of the compression, sometimes it didn't actually follow the vertical meridian, giving rise to such a mimicker. And remember that even after the tumor excision, you can have residual visual field defects. So they can be really good mimickers of glaucoma patients. And the practical tips is first to take a history. Second, I find color vision again very helpful in distinguishing them from glaucoma patients. Usually for compressive optic neuropathies, they will have a diminished red-green color vision. And always read your visual field side by side. And sometimes you will do need a neuroimaging, particularly in patients which you feel again odd when you're seeing a discorrelation between your visual field and OCT retinal fiber layer, and sometimes in very young patients with advanced glaucoma. So here's another case. 49-year-old gentleman referred to me for progressive normal tension glaucoma with a very good vision. Again, the patient was being put on Timolol, and however, he can't tolerate any further medications, and that's why he come to me for any further treatment. And so you'll be able to see that the visual field definitely progresses a little bit, but again, I would say that over the left side, in fact, it follows a little bit of the vertical meridian, which make me feel a bit suspicious. So in fact, what is this? So further history taking again, this time again, I've picked up the history of having a pituitary tumor with excision. So probably this is just a residual. So is the patient actually do have a glaucoma or not? Or is there any other thing else? In fact, still, the patient, I ordered a new MRI for him, and eventually this is a recurrence of tumors, okay? So in fact, learn also that it is important to distinguish compressive optic neuropathies not only at the time of diagnosis or when you have patients who come to you with progressive visual field loss. That means they might be being diagnosed for some time, and when they have a progression, it might be the progression of the tumor instead of the glaucoma. So here are some of the other type of things that can give rise to visual field loss mimicking glaucoma. There's a stroke in the posterior pathway. So any other things that can be a mimicker of our glaucoma patients in our locality, myopia can sometimes give rise to a very different types of various types of visual field defects which can mimic glaucoma. And they can be optic disc tilting, myopic staphylomas, and sometimes lamino-crebosa defects. And sometimes they can give rise to a lot of different CR scar and CNV, which can mimic glaucoma progression. So I'm not going through these type of things here, but I would like to put this here so that everyone knows that there's something else apart from what I've talked about. So take-home message is that differentiation of glaucoma or not should not be merely based on the pattern of visual field defects. I hope that the different types of cases that I've shared here today has highlighted this point. And a clinical review, particularly if they are not done previously, should be performed while you're assessing your patients with glaucoma, especially during the time of diagnosis. Careful history taking on previous operation, particularly cranial operation for tumors, any previous history of trauma, or any other tuberculosis history taking medications, any previous history of drop in visual acuity. I find color vision very useful. And of course, you still need to look at the disc to look for the disc morphology, particularly for sectoral pallor, pit, drusen's, coloboma. And I think the OCT visual field correlation is a very good hint. And if you please suspect the patient to have other things, beware that you need to order a proper neuroimaging. I would suggest ordering MRI brain and orbit and pituitary with contrast, and in some of the cases do B12 folate examinations and to rule out syphilis. And in some of the patients, you still need electrodiagnostic to rule out some silent cone rod dystrophies. So thank you very much. This is the end of my presentation. And I also like to invite you guys to Hong Kong if you have a chance that we are holding our annual scientific meeting in December together with the 12th Asian Neuro-Ophthalmological Society meeting. So thank you very much.
Thank you, Dr. Noel. Your last slide was very, very important. The take-home message, especially for this glaucoma masquerade, they are very, very important. I would ask our panelist, Dr. Ankur, to give comment about this talk or any questions. Ankur, you are not audible. You are muted.
Thank you, Dr. Noel, for such nice show of cases. You covered almost all parts of different features neuro-ophthalmology can come up with different visual field defects. And I agree with her. It is the clinical impression of disc which is more important to go with the neuro-ophthalmology. And in Indian scenario, I just want to add that we do have ethambutol toxicity is commonly seen. Sometimes you have bitemporal hemianopia. You have a history of TB and the patient was on ethambutol. And lately, because of linezolid being used in the multi-drug resistance tuberculosis, we do have some patients of linezolid toxicity, which can present with visual field defects and disc pallor. Also, just want to add that sometimes a contrast sensitivity testing can also help us in picking up optic neuritis and other forms of disc changes which can be there. Thank you again.
Thank you, Dr. Ankur. Dr. Noel, there's a question for you. How to decide on starting treatment in myopic eyes with advanced cupping, RNFL defects, RNFL defects, and visual field defects, but normal IOP?
Yeah, that is a very tricky question. That's why you see I only use one slide to go through that, because it's really difficult. And I think that will owns another talk to tell you apart myopic disc and true glaucoma. And I think sometimes we just get a mixture of these. And to me, I would just have to discuss with the patient very carefully. And I think depends to me, I think the pressure the pressure actually matters. Like if it is already a very low teens type of normal tension glaucoma, and this is a very myopic patients with a lot of PPA, which OCT doesn't work, and the visual field defect is more central, and there's a lot of CR atrophy, and I don't actually think that it is a glaucoma. I'll just monitor them and without giving the medications. However, if the pressure is of a high teens group, like I will tend to treat them while monitoring them at the same time. And if the visual field doesn't actually progress, and I'll just keep them on a small amount of medications. I'm not sure how other panelists do about that, but this is my usual practice.
The same thing we all follow, Dr. Noel. One more thing I wanted to add is in this glaucoma masquerade, we are coming across a lot of cases of optic pit with peripapillary retinoschisis. So usually as an ophthalmologist, we order the OCT and the optometrist does the OCT, the 21 line HD line raster. But I think we all should go to the OCT room, sit on the machine and see each and every slide section which has been taken. Quite a few times we feel there's a field defect, there's a RNFL thinning. But if you look at the line which crosses, there might be retinoschisis. So this is also one of the very rare entity of peripapillary retinoschisis, but we came across quite a few cases recently. So thank you, Dr. Noel, for this wonderful talk. And now I'll go for my next talk, and my next speaker, Dr. Fabio. Dr. Fabio is a very good friend. Yeah, Fabio, can you just stop screen sharing? I'll just show your CV first. Yeah, so Dr. Fabio, he's the head of Glaucoma Institute at Belo Horizonte, Brazil. He's a research collaborator at the Mayo Clinic, USA. Dr. Fabio has 46 publications. He has published 3 books and he has 3 chapters. He's a scientific journal referee for optometry and visual science, British Journal of Ophthalmology, Arquez Peritonealis de Ophthalmologia, and Journal of Glaucoma. So over to you, Dr. Fabio. Waiting to hear the insights from your side.
Thank you so much all for invitation. It's a great pleasure to be here. Thank you, Dr. Bazak, Sharma, and Amit. It's a very important moment in our professional life. So I'll talk about about some glaucoma surgeries, trying to bring a rationale for indication of each procedure. These are my conflicts, none of them related to this presentation. Since 1907, the first trial was described on that time. We have several different glaucoma techniques available to manage our glaucoma patients. So sometimes we still have here in our country some ophthalmologists saying that there are no glaucoma surgeries yet, and our patients keeps going blind day by day. So trying to put together all these glaucoma surgeries is not an easy thing. So we are going to talk about a little bit SLT, some MIGS, iStent, KDB, Bang, and GAT, the MIPS, Zen, and PreserFlow, as transscleral cyclophoto, and some stylizing glaucoma surgery. So how do we put this together? First of all, we have to consider the IOP reduction. It's well known that SLT also maybe drops the interval pressure from 5 to 6 millimeters of mercury in 70 to 75% of the patients, and it lasts for at least 12 months. iStent drops the IOP in something between 1.6 to 2.3 millimeters of mercury and 0.4 meds. KDB, 2 to 4 millimeters of mercury and about 1 med. Bang, 2.4 to 3. We don't have a literature that support this, but we are running some papers regarding Bang, and 0.9 meds. GET, consider MIGS, maybe is the one who really drops the intraocular pressure to from 2 to 6 millimeters of mercury and 1.4 meds. And of course, now we have the Zen and Persiflow. Maybe 51% of the patients achieve the intraocular pressure below 18 millimeters of mercury. And this cyclophoto transcleral, maybe 90% achieve the IOP below, decrease IOP in 30%. So we have several different techniques. And for advanced glaucoma, we have to consider the trab, maybe tube, because it's the one who brings the IOP to low teens and drop it more than 30% and probably brings to 1-digit intraocular pressure. Before we start, we have to consider some scenarios. If the patient has open or closed glaucoma, we have to stage this disease. We have to consider if the disease is stable or we have progression, the number of medication and its compliance to these drugs, and the presence of absence of cataract. And to be more fair, we have to also consider the same payment. The cost will be the same. So just let's think about the procedure. So I tried to bring some scenarios. In this case, we have an open angle with ocular hypertension under meds or initial control glaucoma with no cataract. Which surgery will be the best in this type of eye? So I would consider the SLT for sure, is my choice. And of course, you have to consider these indications, focus on your environment and your experience. So if this patient, the same patient, it presents with cataract, so we have to consider a mix, maybe I stent, KDB, or Bang. If this open angle patient, open angle eye with initial glaucoma or moderate glaucoma with no cataract, we could go for a standalone mix, KDB, Bang, or GAT. Particularly, I do not agree. I do not like to go for KDB and Bang alone. Or we can also consider some transscleral cyclophoto, maybe in this case, a micropulse or a slow burning technique. If we do have open angle with initial and moderate glaucoma with cataract, for sure, I would go for a phaco mix. I think this would be the best choice, and the mix you can choose by yourself. Or a phaco transscleral cyclophoto is not my first choice, but you also can consider this technique. If you have an eye with open angle, moderate and advanced glaucoma with no cataract, you should consider trab, cyclophoto, or a MIPS. So one of these would be a very good choice for this eye. An open angle, moderate or advanced glaucoma with cataract, we also could go for maybe a GAT, MIPS, Zen, or Persiflow, and a facilizing surgery as a trab with cataract. So we can put all of this together, combining surgery with one of these procedures. I think that in this advanced case, I will not go for a GAT and look for more Zen or MIPS and trabs. In another scenario, if we have angle closure with meds, using meds, with initial and stable visual field defect, with no cataract, I think that isolated phaco alone would be enough, would be able to control this glaucoma. If you are facing an ophthalmic eye, a small eye, very short eye, you should associate with a posterior vitrectomy. And also, a transscleral cyclophoto could be considered together with the phaco. Usually, we have very good results in this case. Another scenario, angular closure with initial and stable glaucoma with meds, with cataract, for sure we have to take out this cataract. So once we take out this cataract, we can control this glaucoma in most of the patients without any medication anyway. Angle closure with moderate and advanced glaucoma with no cataract. So we have a clear lens. In this case, we can go for a trab. We can go for a cyclophoto, transscleral cyclophoto, associated or not with phaco. Usually, I do associate with phaco because this shallow anterior chamber in post-op is very complicated to manage. The same case, angle closure, moderate, and advanced glaucoma with cataract, we have to consider phaco, of course, plus cyclophoto or a phaco trab would be good indications. Some specific situations in pigmentary and serous foliation glaucoma, for sure, SLT would be the best choice. If we do have a cortisone or juvenile glaucoma, in my case, I do like to go for a GAT. So we have very good results with GAT in this type of glaucoma. If we do have a new vascular glaucoma, silicone oil in the eye or uveitic, we should consider a tube instead of trab because we have better results and they last more than trabs. Another specific situations, new vascular glaucoma, post-corneal transplantation, post-traumatic glaucoma, dry eye, or silicone oil, I would consider a transscleral cyclophoto. And you have to be very aware in case of new vascular glaucoma because we are facing some ischemic eyes, and we also in dry eyes because we can have some corneal damage in the limbus, and it's difficult to deal with that. Some other specific situations in patients that we cannot have a very confident follow-up after the surgery, the post-op may be a little bit complicated. I would go for a cyclophoto because I think it's a safe procedure and the post-op is very easy to manage. And also we have few complications on that case. So once we have several different procedures in glaucoma, we don't need to be a one technique surgeon. So we have to know and we have to deal with all of these techniques to better indicate for each case, for each eye. Thank you, Amit, for the invitation. I know that you have worked very hard to make this happen, and I'm very happy to be here.
Thank you, Fabio, for the wonderful talk and for summing up and what type of glaucomas, what procedure to know. But one thing which is very important is we all glaucoma surgeons have to be versatile and we should know how to do each and every glaucoma surgery. I would like Dr. Satyan to ask our comment regarding his talk.
Thank you, Amit. First of all, I sincerely thank Dr. Fabio Kanadani for his wonderful talk. And I think it is quite difficult to say in a very short time that covering the entire spectrum of glaucoma and what surgeries possibly you can do. But I think he has covered most of it. But I think we have to really kind of individualize something like how we set the target pressure for the glaucoma patients. It has to be really individualized. There are many factors. It is not a single factor which really decides, especially in Indian scenario. It could be the economics. It could be the follow-up, the compliance factors. There are so many factors which needs to be considered. But in general, as a, like what could be the possible procedures, I think you have covered it wonderfully well. I think each region, again, it really varies because of the insurance cost and so many availability of the medications. Everything matters a lot. So thank you so much for your wonderful talk.
Only one thing I would like to mention. In India, you mentioned in angle, closed angle, stable, mild to moderate glaucoma, phaco. So we are very conservative when it comes to only clear lens extraction. If it is a mild to moderate glaucoma, closed angle, we would go for other options, meds, or might be, we won't go for a clear lens extraction. We are very conservative in that. Other than that, I think the scenario at your country and our country is the same when we look at the economic status, follow-up of the patients, and we follow the same regime. Dr. Rajul, you're logged in. Any comments about this talk?
So, Amit, one, I totally agree about clear lens. We definitely are very conservative. But if there's early cataract, I would definitely be very keen on doing the cataract surgery. 2, 3 reasons. One, the space is so less. So if the cataract, especially if there's nucleus sclerosis, it becomes little difficult if the cataract is hard. So early cataract, I would definitely, clear lens definitely no. The second thing, Dr. Fabio, in multiple times you were talking about the destructive procedure. So I am very skeptical about doing the destructive procedure in primary glaucoma, especially as early moderate, because we have so many options of different mix, trabeculectomy, implants, valves. So I would put destructive procedure at the end of my list. I'm just wanted to ask Dr. Fabio that why so much of emphasis on the destructive procedure. But even micropulse is much safer than the diode. Is still at the end of the day is a destructive procedure. So I would be very reluctant doing destructive procedure is my first line or second line of surgical management.
Is it a
Yeah.
micropulse? Probably he was mentioning,
Yeah,
I'm not
he's
sure.
mentioning the micropulse
Yeah,
itself.
Satyan,
Fabio, can
Satyan,
you?
that's good. But micropulse, it's the end of the day is a destructive procedure. Much safer than diode, much safer than diode, but it's not like we don't have any other choice. We have so many choice doing other options.
Dr. Rajul agreed. Dr. Fabio, actually, you mentioned TSC-PC as one of the surgical choice for many indications. But we in India, we are very conservative in following TSC-PC as a primary indication for seeing eye. So, Dr. Krishna sir, can we have a comment from you regarding the TSC-PC, which Dr. Fabio is mentioning as one of the surgery for most of the conditions?
Yeah. Fabio, it was a very elegant presentation of all the scenarios, and I think he has given his point of view. As far as the cyclophotocoagulation is concerned, I concur with both of you. We do not do it as a primary or adjunct procedure in mild to moderate glaucoma. In advanced glaucomas, either to temporize the IOP control prior to any more invasive procedures, or in situations where we are left with no choice, like in post glaucoma filtering surgeries, post tubes, or in difficult post via surgeries due to silicone oil, we do it as a primary procedure, but not in the primary glaucomas. Only primary glaucoma situation where we prefer is an advanced primary angle closure, where intraocular pressures are high in spite of treatment, and any surgical management is going to be very high risk. There we prefer. Otherwise, in mild to moderate glaucomas, where as Rajul mentioned, where other procedures can have more predictable results, we are usually very skeptical about doing diode.
Can I just modify that? Is it that in
Yes.
a primary glaucoma, we never advise a cyclo procedure, or after doing all the other procedures, if it is not working, then we go for it? Can you just refine that so that the audience have
Usually,
been,
yes.
so we have done a
Usually,
trap, we have done a repeat trap, we have done a tube, everything has been kind of failed, and then we do go for it. We are not saying that in primary glaucoma it is not indicated. We are going to say that when other procedures are going in for a failure, then we still go for a diode. Can you
yes,
just?
it's a little more clear.
I do agree with all of you. When you see to the past, I mean, when I was Bob Reed's fellow, he used to use SLT before going to TRAB. So the patient was under meds for a long time, and before TRAB, he used to try SLT. And now, 20 years after then, we can see that SLT maybe is the first choice, first glaucoma treatment choice, is maybe before meds in our practice. So when I start doing cyclophoto, the transscleral cyclophoto, this is not the conventional one, or I'm doing the micropulse, or I'm doing the slow burning technique. We do not destroy the ciliary body as the conventional cyclophoto. I started only like you in very advanced glaucoma patients after failure trab or a failure tube. So I was going to perform a cyclophoto. So I tried to. I did my PhD and my post PhD on that. studying the cyclophoto, and once we start doing that, we saw that we do not have complications as hypotony as we thought that we would have. So once we are facing very few complications, we start using that in patients with good vision. So we are just finishing to publish a paper. We are writing 2 papers regarding that, the use of cyclophoto in patients with good vision. And why we are doing that? Because the cost maybe is lower than MIGS and MIBS. We are all, Brazil is a developing country, so we have cost problems also. Maybe the post-op follow-up is much easier and the patient has no bleb. So on that point of view, what we are using a very low energy, and we can use it more than one time. So we can use that more than once. Instead of bringing a very high level of energy and with several different complications and possible complications, we are using a very low energy. And I think that these are bringing us a new opportunity to treat these patients without a bleb and without the cost of the MIGS and MIB that we have.
Thank you,
Yeah,
Fabio.
I think we all have a kind of a mindset that we all do it the same way. When there are so many different ways and when you have a different parameters, the outcomes are completely going to be different. So unless we see what kind of a parameter, so it is better we kind of, thank you.
This is Paul Pomberg. Let me just quickly say, Richard Lee in my place has been using cyclodestructive procedures as a primary treatment for glaucoma when he goes to Haiti, where there's just no possibility of medical or surgical treatment of any kind. And I think after SLT has been tried in medications, he's been using it as an alternative to surgery. I'm not switched over to it, but I do find that he is producing some data that we need to look at, and if it still looks as good at 5 years as it has at 1 or 2, then this may be more important than we have thought in the past. That's all. Thanks.
Thank you, Dr. Bamberg. So last speaker for this webinar, Dr. Christopher Leung, a great person, very nice person to know him. He's the chairperson of Department of Ophthalmology, LKS Faculty of Medicine, Hong Kong University, founder director of Hong Kong University Eye Center. He's a clinician scientist with research focus in glaucoma detection and diagnostic imaging of the optic nerve. Dr. Chris has been playing a leading role in introducing key concepts and new technologies for early diagnosis of glaucoma and detection of its progression, new treatment strategies for neuroprotection and neuroregeneration in glaucoma and optic neuropathies. He is recipient of 28 local and international awards and honors in research and professional services. So Dr. Chris is going to talk about the 4th edition of the Asia Pacific Glaucoma Guidelines. We also have Dr. Chris Indian guidelines, and we would like to hear about the 4th edition of the APGS guidelines. Over to you, Dr. Chris.
Thank you very much for your very kind introduction, Dr. Paval, and I also thank your very kind coordination and inviting me to speak in this symposium. I will just give you a brief update of the 4th Asia Pacific Glaucoma Guidelines. I understand it's over, after 9 o'clock, many of you may not have dinner yet, and I would be quick. So the last guideline was the 3rd guideline, which was published in more than 6 years ago, 8 years ago. And the chair back then was Professor Tin An and Professor Jonathan Crowston. And this year, we just released our 4th edition in the Asia Pacific Glaucoma Congress in May this year. I worked with Professor Tina Wong on this publication, and with that, we also have a panel of session leaders from Japan, Malaysia, Thailand, Australia, Philippines, Hong Kong, South Korea, Singapore. We also have other contributors, authors from India and other places of Asia. So it's a group effort with a goal to highlight, to summarize some of the key developments in glaucoma diagnosis management, so as to update our glaucoma colleagues and also comprehensive ophthalmologists throughout Asia Pacific region to know what's the updates we have in relation to glaucoma management in this region. In the last edition, we basically only had 3 sections: assessment, treatments, follow-up. Pretty simple, straightforward. This year, we have a slightly different format where we have 5 different sections, including epidemiology, diagnostic workup, management approach, medical treatments, and surgical laser treatments. And one key feature that this edition has is in each individual section, we also have key messages or some consensus points, such as to highlight the key elements that we can gather from the section. So I just go through some of the highlights in each section. As I said, I would not have time to go through everything, but I would like to point out some of the new things, new ideas, and new concepts, new consensus points that we have to gather from this 4th edition. In the first section, I think it's very important for us to recognize that glaucoma is the leading cause of irreversible visual impairment and blindness worldwide. In the old day, when I wrote Grant when I was a junior faculty, or many of us here would say, well, glaucoma is a leading cause of irreversible blindness. But in fact, based on the latest research, latest epidemiology finding, population-based studies, we know that glaucoma is actually the leading cause of irreversible blindness. When we look at the global burden of disease, blindness, and visual impairment collaborators work group, what we found is that obviously cataract is the most common cause of visual impairment and blindness, but it's not irreversible. But for glaucoma, when we look at the global prevalence, is now we have 11%, more than age-related macular degeneration, 5.6%, and diabetic retinopathy. So glaucoma, AMD, diabetic retinopathy, these are the most common causes of irreversible blindness, but glaucoma by far is still the #1 in the list. And when we look at the South Asia or Southeast Asia region, glaucoma is still the #1 cause of irreversible blindness. Obviously, we see pretty high prevalence of cataract in this region. But when we look at the high-income regions, although the study really didn't define what countries are high-income countries, but what we have here is glaucoma is actually has a higher percentage, higher proportion in this category compared with cataract. So we have 28% of the high-income countries, 20% of the population in high-income region having glaucoma as the leading cause of irreversible blindness, far more higher than age-related macular degeneration and diabetic retinopathy. So this is an important idea. This is an important message that we need to get across. It is important and we need to detect the disease early. In the Asia Pacific region, 70 to 92% of POAG cases have normal tension. Again, this is an important idea. Japan, Korea, China in particular, we have high volume of cases of normal tension glaucoma. Intraocular pressure is not the diagnostic tool for glaucoma diagnosis, and we need to examine the optic disc carefully. Surprisingly, and actually not that surprising, a lot of patients actually are not aware of the disease. So again, that also highlights the importance of perhaps glaucoma screening is of particular importance. And we don't have a good tool yet to identify glaucoma reliably with high sensitivity and specificity. But with OCT, with latest technology, I think there is hope that we can implement some of the latest technology to identify the disease early so that we won't miss the treatment window. So targeting high-risk population and implementing cost-reducing strategies can make glaucoma screening actually cost-effective. I think this is, again, a very important idea that is delivered in this session. Second section is about diagnostic workup. One key, obviously important diagnostic workup we perform in every patient suspected of or with glaucoma is intraocular pressure measurement. Global appendage tonometry is still the gold standard for IOP measurement, but we also notice that there are a lot of new tools, new tonometers that allow us to measure intraocular pressure. One such tool is the Webang tonometry. We understand this is an important way to measure intraocular pressure because not only it is comparable in terms of the measurement. We have comparable measurement with Glaucoma tonometry, but also is related to the fact that we have home monitoring model. So the iCare Home 2 actually, in fact, right now is the only FDA-approved tonometry device that allows patients self-monitoring at home. That said, we don't know yet at this point whether this home self-monitoring IOP can change clinical outcome. Although we know office measurements are just not sufficient to capture IOP changes, to capture IOP profile for our patients. We need more pressure readings to guide our management to pick up the peaks that we may miss during office hours. But we need additional investigation to tell us how much this home self-monitoring would be useful to guide treatment outcome, whether it would be cost-effective, whether it would lead to better clinical outcomes. The second, and I think perhaps more important, diagnostic workup that we need to always be aware of is evaluation of the optic disc. Nowadays, we're using OCT more often in addition to visual field. One key message that we gather from the 4th edition of the guideline is that we need to rely on wide field imaging. Wide field imaging means we need to cover the parapupillary region and the macula for retinal nerve fiber layer and ganglion cell inner plexiform layer thickness measurements. We used to rely on very much the circle ring or the circle scan measurements of the retinal nerve fiber layer, meaning that we use a 3.6 millimeter diameter of circular scan around the optic nerve head to measure the retinal nerve fiber layer. And then we look at the normative database reference to tell us whether the thickness measurement is below or within the normal reference. But we know nowadays that this is grossly insufficient. Here is an example to demonstrate these points. The panels on the left show you the circumpupillary measurements. The lower panel show you the circumpupillary measurements. The upper panel show you the rim width measurements. So they all look normal. When you look at the our NFL profile plots and also the minimum rim width measurements reference, and they all are within normal limits. They all are normal. Now, when we look at the panel on the right-hand side, this is the retinal nerve fiber thickness map. The red indicates thick, the yellow indicates thin retinal nerve fiber layer. With the map, actually, we get more information about the retinal nerve fiber layer structure. We know the distribution of the retinal nerve fiber layer, and which that gives us a better idea whether there are retinal nerve fiber defects. In this example, we notice that it appears the supraorbital retinal nerve fiber layer is thin, and in the deviation map, actually, we notice an island over there highlighted as abnormal. The challenge here, very often, we feel it difficult to determine whether this is false positive or it is a genuine defect. When we look at this display, this is called rotor or retinal nerve fiber optical texture analysis, a technology we developed 2 years ago, which show the individual trajectories of axonal fiber bundles. What we have here is a clear retinal nerve fiber defects of the supratemporal side. You can see the axonal fiber bundle fibers are well there in the inferior arcuate bundle, but for the superior arcuate bundle, we see a clear defect, which corresponds pretty well to the RNFL thickness map. So the idea here is we need wide field capture. Not only we need to look at this parapupillary region, but here we are using the wide field 12 by 9 millimeter, covering both the macula and the optic disc. And the reason here is that retinal nerve fiber defects are often wedge shaped, meaning that the defects size expands from the optic disc towards the macula, towards the peripheral retina. If we are limiting ourselves to look at just the rim, if we are limiting ourselves to look at the ring measurements of the RNFL, we are going to miss a lot of retinal nerve fiber defects. In particular, where we will be missing a lot of local early retinal nerve fiber defects, like this case shows. Here is another example demonstrating the importance of not only looking at the thickness map of the RNFL over the optic disc region, but in this case, we also need to look at the GCIPL thickness analysis of the macula, because when you are looking at the RNFL thickness map alone for the left eye, you can see we would miss our RNFL defects. It's only when we look at the macula, when we see the expansion of the retinal nerve fiber defect, we are able to pick up the defects that can be missed by just looking at the ring, by just looking at the retinal nerve fiber around the optic nerve head. So that's why the key idea is we need to look at wide field. The current OCT platforms are complicated because many of us use different types or different models of OCT systems. They all give different measurements and they all use different ways to measure retinal nerve fiber layer. And so that makes things really complicated. The panel above is the series model. The panel below is capture with the TopCon OCT. So depending on how large you image the retina, depending on what scan type you use, you may get slightly different analysis, different outcomes. But the idea here is we're able to use wide field scan. Please use wide field scan. And please, if you don't have wide field scan, you can scan, say, for example, in this case, for series OCT, you can scan the optic nerve head and you can scan the macula, and then you can use both images to make an assessment. For perimetry, we notice that it is important. We need perimetry, not particularly for diagnosis of glaucoma, but we need perimetry for follow-up. We need perimetry to guide whether there is progressive changes that may need us to change in our treatment regimen. Very often, we're using 24-2 or 30-2. A lot of us are using Humphrey field device. I believe the Humphrey field analyzer is the most popular visual field device we use in Asia, in America, in EU, in Europe. Some places use Octopus. But in Asia, I think a lot of us are using the 24-2 and 34-2 from the Humphrey field analyzer for visual field capture. Very often, we don't know when to administer the 10-2. We often are told that when the disease is advanced, when the 24-2, 30-2 are all wiped out, we may need to 10-2 because we need to focus on this area to get us more information about visual field change over time. But here, I think it is important for us to understand that we need 10-2 when we see damage of the RNFL or GCIPL over the macula. The reason here is that even for cases, in this case, we have a pretty early glaucoma. We only have a supranasal visual field defects. The reason why we are missing central visual field defects is the 24-2 or 30-2, they only have 4 visual field points targeting at central 10 degree. So if we have defects, in this case, we do have papillomacular bundle defects and actually papillofoveal bundle defects in this case over here as shown by my arrow here. In addition to the inferior accurate defect. If we are using a 24-2, we're going to miss the central defects. So 10-2 is also important in this case, not only to illustrate how much, to what degree the visual field, central visual field 10 degrees is lost, but also in terms of monitoring the changes over time. It is important because this area is close to the fixation. You would like to follow this area very closely. If there's any change, any worsening, you need to add up, you need to augment your treatment. So when we see nerve fiber defects over the macula, when we see GCIPL defects over the macula, we need 10-2. Session 3 is about management approach. I think Ben already covered that in his lecture. I'm not going to elaborate that, but I think the key point here is based on the recent clinical trial by Ming Guanghe. We noticed that a lot of PACS cases, they progress very slowly, and not all cases of PACS require prophylactic LPI. What is missing here is what kind or what patients with PACS would require prophylactic LPI. I think this is something that we would like to address in the coming years, using perhaps AIOSSC technology to highlight how the degree or extent of iris trabecular contact to give us an idea who would be more likely to turn from PACS to PAC. Those cases would require LPI. Session 4 is about medical treatment. There are new medication we have, including the EP2 agonist, role kinase inhibitors. So the new updates have some cover on these new medications. More important, we also noticed that there are side effects related to glaucoma medication, ocular surface disease. We are now more aware of this particular problem in our populations. That's why we also have more preservative-free options now than before, and we also are more aware of prostaglandin-associated periorbitopathy, which is a very important syndrome among our patients using PGA, because these patients tend to have sunken eyeball, pigmented iris, pigmented lids, and for IOP measurements, many of these patients may give us an overestimation just because of the tight eyelid. And when we need to elevate the lid, that could lead to overestimation of ventricular pressure. That also leads to another advantage of the rebound tonometry that I mentioned earlier. The beauty of the rebound tonometry is that you don't need to elevate the lid, you just have a relatively non-contactable. You need the probe to contact the cornea, to contact the apex, of course, but you need less contact of the eyelids so that you can avoid pressure elevation. The last section is about surgery. I think we have a lot of discussion this evening already. I don't think we have time to go through individual parts. And in fact, we don't have any good consensus at this point regarding which particular MIG surgery should be selected on a certain condition. And we don't yet have a very good clinical trials informing us when to perform MIGs, when to perform GDD, when to perform trabeculectomy. I think with time, when we have more clinical trials, we would be better informed how to tailor this surgery against other types of conventional filtration surgery, against other types of glaucoma intervention, including laser, including SLT, including cyclophotocoagulation. With that, I'll stop there. Thank you very much.
Amit, you're muted.
Yeah, thank you, Dr. Chris, for highlighting the guidelines, Asia Pacific guidelines, the 4th edition, and how different they are from the 3rd edition and what new things have been added. It is not an easy task. You and Professor Tina did a great work in a very short span of time, as you had mentioned it in Manila. And we also have our own Glaucoma Society of India guidelines. And this was published when we have our panelist over here, Dr. Chandrima Paul. She was the secretary, and Dr. Rajul Parikh was the editor. Both of them are there as a panelist here. And they came up with the first time in the history, we have the GSI guidelines for our own all Glaucoma Society of India members. So because they were part of this, and you also have been part of the Asia Pacific guidelines, I would like to take input from Dr. Rajul and Dr. Chandrima regarding how helpful these guidelines are, not only for the glaucoma specialist, but also for the comprehensive ophthalmologist. Dr. Chandrima, your comments?
Yeah, so I think these guidelines are very, very important. And I think for the Asia Pacific, the Southeast Asian countries, it's very important. And for us, the Indian guidelines are slightly different from the Asia Pacific because it's very specific to, the studies that have been conducted all over the country, but they've never been recorded in a concise format as was possible in these GSI guidelines. So I think they are very important for that particular region in which, you are practicing, because you get a very evidence-based report regarding how you should proceed. It's basically a day-to-day Bible kind of a book that you can actually go through. And Dr. Rajul has been the chief editor for that, so he can highlight a little bit about that.
Dr. Rajul?
So, yeah, Amit, it was any guideline is a very daunting task. This really, I was there as one of the reviewer in third APGS guideline. I think they've changed quite a bit, but most of the guideline basically is helpful for the mainly for general ophthalmologists, because most of the glaucoma specialists would keep in touch with the latest research and the latest update. So for the general ophthalmologists, this kind of guideline, if they keep by the table, then it's really useful for the day-to-day practice. And I think Indian guideline, the only why we wanted it, because it's little different than European guideline. Because European guideline, of course, they're one of the best guideline, I would say, because they have incorporated lots of evidence-based approach, which we should in our next guideline when we update. The first guideline, we wanted to keep it little bit more simple for all the comprehensive ophthalmologists. But if we decide to do second, then we should have more evidence-based approach what the EGS is doing. But I would say that because we have so much of difference in the representation of glaucoma, I think Indian guideline covers little bit more compared to EGS and APGS for the day-to-day practice. We have covered more secondary glaucoma, specifically more angle closure glaucoma. So that way it's little different than the other guideline.
Dr. Chris, I was lucky to have this book in my hand when I was there, the 4th edition. And when I compare to the 3rd edition, it is quite informative. But as Dr. Rajul was mentioning, I think the 4th edition needs some revision, as we had discussed. I think these guidelines, most of the glaucoma specialists know how to practice. These guidelines, we should all work on how to make it available to the comprehensive ophthalmologists. These guidelines are needed by them more than the glaucoma specialists. So even with GSI, we have distributed the guidelines to all our GSI members. But what I would say is we should distribute to all our AIS members. Same thing with Dr. Chris. We are going to distribute these guidelines to all the APGS members. But I feel at least the soft copy, if it is available on the Google, on the web, any comprehensive ophthalmologist can download it and can have access to that. That will be, that will justify the amount of hardship which all of you all have put into it. Because ultimately, whatever guidelines come, whatever hardship you have put, it has to be benefited to the ophthalmologist who's going to practice.
Sure.
Amit, you are there.
Yeah, go ahead.
Just Amit, you are there, and Namrata madam is here. We have the PDF of the Indian guideline.
Yeah,
is it possible to put on here?
Yeah, so I think it can be
we are ready
mailed,
to put it.
Yeah.
Me and Dr. Namrata will be ready to put it and circulate to all the AIS members. We just need permission from the GSI office. If GSI allows it, we will shoot it off to all the AIS members. All the 28,000 AIS members will have the access to these guidelines. So we'll need permission from you. You are the editor, you have to work on it. We'll distribute it.
Okay.
You know, Dr. Namrata? Yeah,
I think it's a good idea to perhaps, each individual region in the Asia Pacific place is unique. And I'm sure the guidelines that develop from India has high relevance, importance to the local population, to the local glaucoma specialists in India. At the same time, what Dr. Roger shares, preparing guidelines is really, really challenging and difficult. And especially we're talking about the Asia Pacific region. It's huge region. It's very diverse, population characteristics, and formulating guidelines is extremely, extremely challenging. But then I also would say, that's why individual guidelines from individual region plays an important role to see how we may actually learn from our colleagues in different parts of the world, how we practice glaucoma. We may practice slightly differently depending on where we are. And I think it's a good addition there if we can actually perhaps pull up the India guideline in the Asia Pacific Glaucoma Society website. The Asia Pacific Glaucoma guideline is going to be available there too, so that people can, better utilize these references depending on where they come from.
Yeah. So Dr. Chris, as I mentioned to you, I'll send you the GSI guidelines also, because we need to do some changes. You need to do some changes in the 4th edition you were mentioning. So that can be of help, the GSI guidelines, for you to make the changes based on the regional basis. And thank you, Dr. Chris, for this wonderful talk. And before I wind up, there's repeatedly one question which is being bombarded to me. And this was basically for Dr. Keith or Dr. Paul. Dr. Paul Bamberg is here. Just want to have a quick answer. The question is, what IOP is too low for a complicated tube surgery? Dr. Paul?
I'm sorry, what pressure is too low?
For a complicated tube surgery.
For a tube surgery?
Yeah. Complicated tube surgery, what IOP is too low? So when would you say for a complicated tube surgery, this pressure will give rise to hypotony?
Wow, I don't quite understand the question, but you don't want to have hypotony complications of, excuse me, hypotony maculopathy or choroidals, but too low a pressure to put a tube in. I think any pressure that's damaging somebody, you can probably get somewhat lower. We have found that bar belts do lower the pressure significantly in
Dr.
people
Pamba,
with.
the question is, when you have put a complicated tube surgery, you have done a complicated tube surgery, at what IOP you might expect hypotony, or you might say that this IOP is too low and this will give rise to hypotony after a
Amit,
surgery.
is it after surgery, post-surgery IOP?
Post-surgery hypotony is the question basically.
Yeah. So at what IOP level the patient will get hypotony after a complicated tube surgery?
Well, I've had people with pressures of 7, 8, 9 who are seeing fine and not having any trouble. I think it's really, that just is defined by what you see. I do think that an OMID should be considered in patients with uveitis, as Dr. Keith Barton said, because there really is a big risk of in juvenile idiopathic uveitis, of having too low a pressure. So the people who don't make much aqueous, you better put in an OMID if you put in a tube rather than something that's not restricted. I hope that's relevant to what the question is.
Yeah.
I have not had a problem. I have not had a problem with hypotony after bar belts in people who don't have reduced aqueous production by either long-standing severe uveitis, particularly in children, or people who've had cyclodestructive procedures. And one of my concerns about doing cyclodestructive procedures is that maybe it will then not be as wise to use a large drainage tube because you could get hypotony. But I've had very little problem with hypotony. The hypotony problems generally happen because people don't reform the eye fully at the end of the surgery when they put a tube in. You want to keep the pressure formed all the time during tube surgery. That's why I like the long tunnel incision put in obliquely, because it doesn't leak. And I think people who put a little viscoelastic in and say, oh, that's going to solve the problem. Well, it doesn't, because viscoelastic does not go back through the zonular diaphragm and pressurize the back of the eye. And if you leave with tube surgery, and I hear people complaining, oh, I use the OMID and I keep getting hypotony. Well, if you really form up the eye and get the pressure up to 15 or 20 and then watch it come down to 12 or something with an Ahmed, you're not going to have hypotony problems afterwards. The problem is if you haven't reformed the eye fully at the time of surgery, you're leaving it low because you had a needle track that was leaking, and during the next few hours, they're forming a choroidal. So that's an avoidable problem. Be sure in any glaucoma surgery, do not leave the operating room with a pressure that is not at least at or above your goal.
Thank you, Dr. Pambak, for this wonderful thoughts of yours. And now we come to the end of this webinar, and I sincerely thank my president of All India Ophthalmic Society, Dr. Sama Basak, my chairman scientific committee, Dr. Namrata Sharma, who always keeps on pushing me and encouraging me to conduct these global webinars so that all our AIS members do get benefited with the inputs from all the stalwarts globally. Especially, that's why we named this session as Top Guns. And my whole governing council of All India Ophthalmic Society and my team of scientific committee members. And this program would not have been successful without the presence or participation of our esteemed speakers, Dr. Paul Pambak, Dr. Keith Barton, Dr. Chris, Dr. Benjamin, Dr. Noel Chan, and Dr. Fabio. And our panelists, they are all stalwarts. They have their own, they have multiple awards. They have got multiple publications. So I would like to thank Dr. L. Vijaya, Dr. Krishnadas, Dr. Tanuj Dada, Dr. Rita Damankar, Dr. P. Satyan, Dr. Chandrima Paul, Dr. Rajul Parikh, and Dr. Ankur Sinha for participating in this webinar and giving your valuable time. I always target the webinar to be of 2 hours, but somehow we land up in spending 2.5 to 2 hours, 40 minutes. There are a lot of questions, but we can't. So I think next time onwards, we'll have a masterclass of one particular topic for 1 hour, and that will give enough time for discussion. And with this, I thank everybody for keeping up so late without food, and people in the US for coming up in this webinar, leaving your busy schedule. And thank you once again to one and all. Thank you.
Thank you.
Thank you, everyone. Thank you, Dr. Namrata. Thank you, Ahmed. And thank you, everyone.
Thank you very much, Dr. Namrata and Dr.